हम्म हाँ न कले नेचुरली कहया पड़ो पिलाटा आसुची ना सबुदिन देखा कर जीता मन देखा करनी
हाँ, हो गया। हाँ, हेलो, प्लीज स्टार्ट द सेशन।
Yes, ma'am. Please go ahead.
आप ऑनलाइन ही रहिए, आप बोलिए, मैं बताती हूँ। हाँ जी मैम। हाँ, मैंने कर दिया।
Good morning, everyone. Good morning, everyone. I, Dr. Manika, welcome you all to the first session of the World Conference on COVID and Critical Care. We're honored here to have our esteemed faculty and speakers from all over the world on board with us today. To begin with the first session of panel discussion on communication with relatives, I invite Dr. Prakash Shastri, Vice Chairman Critical Care, Sir Gangaram Hospital, New Delhi, to kindly moderate the session. Sir, I request you to kindly introduce the panelists for today and continue with the session.
So in this C4C meeting, we are going to have a panel discussion on COVID-associated mucormycosis. I'll be talking about the various panelists in due course of time. But to get the ball rolling, we can discuss about what is COVID-associated mucormycosis. And I'll take a few minutes to share with you my personal experience in COVID-associated mucormycosis. Now, the clinical presentation of mucormycosis is classified on the basis of the anatomical location where the mucor strikes. So normally we have most commonly the rhino-orbital mucormycosis, which can get extended into the brain, where we call it the rhino-orbital cerebral mucormycosis. Then, of course, we can have pulmonary, gastrointestinal, cutaneous, renal mucormycosis, and if all these are involved, we call it as disseminated mucormycosis. So much for the theory of it. So while we know that uncontrolled diabetes is a risk factor for mucormycosis, the entity COVID-associated mucormycosis was hitherto unknown until the COVID struck us down. So I just want to share my data of COVID-related mucor cases that came to Sir Gangaram Hospital, and it is a retrospective analysis which were done for patients who were admitted during September to December 2020. Mind you, this was before the second wave struck our country. So we only took in proven mucormycosis patients in our study, and we defined proven mucormycosis as subjects with compatible clinico-radiological presentation, demonstration of the fungi by histopathology or tissue specimen, or positive culture from a sterile body fluid. So 19 patients were enrolled in this 4-month period. Males were 17, 2 females. The median age was 55 years with a range from 37 to 80. The diagnosis was made after a median of 33 days after the RT-PCR for COVID was positive. But again, here the range you can see from 6 to 78 days is a wide range. So in some cases it struck pretty early, or maybe the patients reported to us late. And in some cases it was reported almost 3 months after the RT-PCR positivity. Majority were known cases of diabetes mellitus with a median glycosylated hemoglobin level of 8.4. Again, you can see the range here, as low as 6 to 13.4. And again, you can ask me the question whether these were new onset diabetes mellitus or whether known diabetes mellitus. These patients had diabetes mellitus even before COVID struck them. Among other risk factors, steroid therapy during COVID episode was the most common. It was seen in 18 out of the 19 patients. Median steroid dosage was 2,400 milligram of prednisolone equivalent, with a range of 840 milligram to 12,500 milligram. So obviously, these patients received steroid, and we know the reason why, because during that period, we got that landmark study in which steroid became a recommended treatment for the treatment of mild to moderate COVID patients, especially who were hypoxemic. And the median duration of steroid therapy was 14 days, which was above the usual recommendation of around 10 days. Again, if you see the range of duration of therapy, it was as low as 6 days, and it has as high as almost 1 month. So there was a wide variability of practice in the institution itself. Forget about what was going on in the second wave, when most of the patients were in home isolations and they were given oral steroids. So as you can see from this picture, I hope it is clear, majority of the patients presented with headache, facial pain, facial swelling, proptosis, visual disturbances, ophthalmoplegia. So naturally, the most common site was rhino-orbital mucormycosis, or 9 patients. 4 of them had extension, not 4 of them, 4 additional patients had extension into the brain. And these were the patients where we did not have good outcome. Then there was one case of pulmonary mucormycosis, sinonasal and sinopalatal. That means the eye was spared in the rest of the patients. So majority of the patients were rhino-orbital mucormycosis, which is in tandem with most of the studies done beforehand also. The most common presentation is rhino-orbital. In some patients, there is a CNS involvement also. So diagnosis was confirmed by histopathology, either by the endoscopic route, or tissue was sent after the operation was done. So here I can say that we evolved a system in Sir Gangaram Hospital in which the moment the patient was seen in the casualty or in the OPD, and the person was suspicious of mucormycosis, an ENT surgeon was immediately called for, and at the outpatient level itself, an endoscopic nasal biopsy was taken, and this nasal biopsy was sent to the microbiology lab, and there was a dedicated person in the microbiology lab who would look into these patients and do a KOH mount of these patients and inform the concerned person, the ENT surgeon in this case, within half an hour to 1 hour. And this is where probably we scored over other hospitals, where that we made a diagnosis very early. And so direct microscopy was positive in 14 out of the 19 patients, but culture was positive only in 5 patients. And this was a problem for which we are doing another study as to why KOH mounts are positive, but somehow or other these, or maybe the sample set is not adequate, whatever reason is there, we are not able to culture these mucor, and that is why species level identification was found in only 5 out of these 19 patients. So there is another study that we are doing as to why culture positivity rates are so low, but yes, that is a fact. The usual treatment was liposomal amphotericin B in all the patients, but 12 out of 19, 63% of patients received posaconazole along with liposomal amphotericin B. Now, there is no justification, no evidence as of now to say that combination therapy works better than liposomal amphotericin B alone. But in this study, we found that maybe the surgeons, the treating physicians were overzealous. They didn't want to take any chances. So that's why they prescribed azole as well as amphotericin B up front, and when the time came to discharge this patient, which was usually after 4 weeks or so, then they were discharged on oral azoles. The surgical endoscopic debridement was done in 17 out of these 19 patients. So surgery, you see, was something which was done very promptly in our institution. Prevalence of CAM, as was calculated by the total number of cases of mucor divided by the total number of COVID-19 patients who were treated in the same period, was 5.47 per 1,000 COVID patients. Among the 19 patients, majority, that is 15 of the patients were discharged, where 3 succumbed to infection infection, one patient left against medical advice, and that is why for worst case scenario analysis, we tend to include this patient also as dead patients. So the mortality in this cohort, which was 4 out of 19, was 21.05%, and the mortality in the COVID patients who were admitted during the same time period was 13.9%. So you can definitely come to the conclusion that the mortality of those patients developing mucor after or during COVID episode is higher. The remaining 15 patients, because of, I believe, a very gung-ho kind of a response to these patients, were alive at 6 and 12 weeks. And so the follow-up was very good and they were followed up. Quite a few of them are even now in our follow-ups. We have come to know their names. They have undergone cosmetic surgery, eye reconstruction, palate reconstruction, even facial reconstruction for that matter. And one more thing that came to light in the study, the number of cases in 2019 during the same time period that we got were 9 patients of mucormycosis between September to December 2019. In September to December 2020, we got 19 patients, suggesting a rise of 2.1 times during the pandemic. And that is where the COVID-associated mucormycosis, or CAM acronym, came to become a uncommon thing. So what we did in our hospital was that if the clear clinical picture of mucormycosis existed, the positive report of biopsy taken endoscopically and the QH mount report was given within half an hour to 1 hour, then the decision was made to put up this patient for surgery as soon as possible, sometimes as late as 8 o'clock or 9 o'clock. The OTs were running all the time. And in one of the meetings that I had during that period, I was talking to a surgeon who was live from the operation theater. And I asked her how many examination has she done during that day. She said, this is the 6th one that I'm going and the 7th one is on the table. So what we are trying to make a point is that culture and histopathology obviously are not required for making a decision for intervention. Clinical findings and imaging plays an important role to define the extent of involvement. And here, of course, I have to really appreciate the work done by our radiologists, because in all cases we got a contrast enhanced MRI done, and this contrast MRI actually told us how much of orbit was involved, whether we could just decompress the orbit or we have to go in for exentration. So this kind of decision making was made easy by our very good team of radiologists that we have in the hospital. Liposomal amphotericin B is the preferred treatment, as I told you, that azoles are used, but not concomitantly, but as a follow-up. So consolidation therapy is done after 3 to 4 weeks of amphotericin B therapy, and it is continued for 3 to 6 months. We have had patients who have been using posaconazole for now almost 9 months now. So the conclusion that we derived from this particular study was that presumably the higher incidence of mucormycosis was presumably poor sugar control. We were not sensitized early on in the management of this patient that COVID patients tend to have poor sugar control. So we should aggressively control it. We were probably not clear, or maybe we erred on the side of caution and gave steroids, larger dose of steroid for longer than necessary period. And finally, a compromised immunity due to immune dysregulation and inflammatory response in COVID-19 patients predisposes these patients to deadly fungal infections. So that marks the end of my presentations. I hope all of my panelists are here. I will introduce all my panelists as I ask them the question. And so indeed, it's a great pleasure, all of you, to have you on board here. And thank you very much, the C4C, CWC organizers, to have organized this world conference. And we are talking a topic of really great interest. India, we knew, was always the capital of diabetes. We know that India has been hit hard by COVID. We have one of the largest populations of COVID patients in the world. And probably, if I might be extending myself by saying that probably we have had the maximum number of mucormycosis cases which were associated with COVID in our country. The study is ongoing. I remember in the early part of the year, Professor Alok Chakravarti and Dr. Atul Patel came out with a retrospective analysis of 4 months, and there they could include around 200 patients of coronavirus-related mucormycosis, and that perhaps was the biggest series that came out in the world. This paper has been published in Emerging Infectious Disease. A second study, a case control study, is on and by the same group, and the results of which are expected in the next month or so. And that perhaps would be the largest study of which has enrolled the maximum number of patients anywhere in the world. So I can say with certain amount of impunity that perhaps besides diabetes, India is also the mucor capital of the world, and COVID has only added to the double whammy that we see with COVID-associated devastation. Mucormycosis is something which, you can't even wish an enemy to have. So to begin with, the first person that I'm going to ask this question is Dr. J.V. Peter. Dr. J.V. Peter is a director of Christian Medical College in Vellore, and obviously he is a critical care specialist. But now that he is handling the portfolio of administration as well, that's why I'm asking this sort of an administrative question to him. The entire country was deluged by the onset of COVID-associated mucormycosis in that period of April, May, June onwards. And during that period, even the government came out with clear directions which were sent to the hospitals as to how to manage these patients, how to handle them, how to ration the amphotericin B. My question to you is, as the director of the hospital, how did you plan the institutional response to the surge in mucormycosis cases? By which I mean, how did you organize or coordinate the various subspecialties involved to have a cohorted kind of a proper response to this COVID-associated mucormycosis? We know that a lot of specialties are involved in this. So, Dr. J.V. Peter, how was your institutional response? I'm not asking your personal response, but your institutional response to COVID-associated mucormycosis. Dr. J.V. Peter, please. Are you there,
so
Dr.
much.
Peter?
Yes, thank you so much for this invitation to be part of this. A very pertinent question, and we also had a deluge of cases, over 200 cases in just 2 months, and 3 months. And so we had 4 different teams as part of this multidisciplinary team. The first, as you touched on very beautifully in your presentation, a diagnostic team which comprised of microbiologists, pathologists, and radiologists. And there was a clear pathway and a protocol for diagnostics. If there was no clear diagnostic on a microbiological smear, and if a patient needed excentration, for example, there was a facility for doing a frozen section to confirm the diagnosis, because being a mutilating surgery, we also felt that clear-cut diagnosis was important before proceeding with that. So that first is the diagnostic team, and the radiology team was also very good in trying to help us out with the extent of involvement. Second was the surgical team, and this comprised of 3 groups. The first is the ENT surgeons, and we had 2 groups of ENT surgeons, one who have specialized in rhinology, and the other group which have specialized in skull-base ENT surgery, and both these teams were involved. We had the entire spectrum of consultant registrar cover for all 24 hours, and these dedicated teams were involved in the first line of surgical management, particularly debridement and debulking. The next set of surgical team was the ophthalmologist. We had orbit and oculoplasty surgeons who were part of this team. And thirdly, the neurosurgeons who also were part of this multidisciplinary team. It took only a few days to bring all these teams together, but once they started work, they gelled so beautifully. The third group was the medical team, which for the COVID, we had only the infectious diseases specialists being fully involved, and there was a predilection to more use of posaconazole than amphotericin for the reasons that you specified. And fourth is the ICU support team, as and when they were required. And out of the cohort of 162 patients that were managed during the COVID pandemic, the mortality of COVID-associated mucor was only 10%. I think the multidisciplinary approach did help in keeping the mortality down and giving the patient the best form of treatment. And this has just been accepted for publication in the International Journal of Infectious Diseases. I'll stop here, and I'm happy to take some more.
One more question before I leave you. I know you're a busy person, you've got other things to do. My simple question was that how difficult was it to convince your patients, once you had made a reasonable diagnosis of mucormycosis, to go in for mutilating surgery? Did you find resistance on that front, either from the surgeons or from the patients?
I have a dual advantage of having my spouse as an ophthalmologist who's also an oculoplasty surgeon, and she's been working on Muco for over 10 years. So they're very clued to how to approach Mucor and the mutilating type of surgeries. The focus was always whether we could preserve the eye and the sight. But if the eye was so much involved that, and there was no sight, it wasn't too difficult to convince the patients for exentration,
Yes.
mainly because it was life-saving. And there have been several examples of excellently fit prostheses that we could convey to the patients to say, okay, your life is more precious than losing sight in one eye. It's not as terrible as you think it is. And showing them examples of how people have got back to normal life helped with this decision making. And I just had a word with her, and she said hardly ever had they had problems with convincing patients when they were really needing to save their lives. So that wasn't too major a problem that the team faced at CMC.
Excellent. Thank you very much, Dr. Peter. It was really heartwarming to see the approach that you and your wife had towards this kind of mutilating surgery. And really, hats off to you and my appreciation. And I convey it to your wife as well, because personally speaking, I have been involved in the muco for some time now, and it was without this kind of a backup and pictorial depiction of eye reconstruction, it is quite difficult. And for me, the beginning was that I could not convince the eye surgeons to do it, because in a private setup, they are very happy doing only cataract surgery all through the day. And this kind of mutilating surgeries are something that obviously they find very hesitant to do it. But COVID really brushed aside all these deficiencies. And during COVID, it became a norm rather than the exception. But before that, definitely there was a problem in convincing my ophthalmic surgeons to go in for this kind of operation. So thank you very much for your answer. And really, I appreciate for you to have spared your time, because I know that you have got another meeting going on, and I'll be allowing you to go if you wish to.
Thank you so
and
much.
we move on with this panel discussion.
Thank you.
Welcome. Dr. G.C.
Yes, I'm
Kilani,
here.
are you there? Oh, great. Welcome to this place. Indeed,
Thank
a
you.
pleasure to
Thank
have
you.
you on
Thank
board.
you.
And you have done a lot of work, and you have been very active on the social media in topics related to the COVID. My question is very, very theoretical. How do you explain the deluge of mucormycosis in this second wave? I mean, in the first wave also we had quite a number of patients. It was only the second wave that we had the deluge of mucor cases. So I've got few choices for you. Now, does COVID produce an immunosuppressed state? So by itself, it can produce, can lead to predisposed to mucormycosis. Were steroids prescribed a little too much, a little too longer? And whether the antibiotics also contributed to it. We have prescribed antibiotics, broad spectrum antibiotics for long period without any justification in this COVID patients. So is it a collateral damage of antibiotic usage?
Thank you, Prakash. At the outset, I
Please.
must compliment you for making an amazing presentation, and you almost covered everything and left very little to us. So, and thanks to the organizer for giving me this opportunity. So first we talk about what we actually know about mucormycosis. We know that mucormycosis, the commonest predisposing factors is diabetic ketoacidosis or uncontrolled diabetes, and also the immunosuppression, especially the transplant patients. Working at AIMS for 30 years, we used to see 1 to 2 cases per year, being a tertiary care hospital. Your question is very right. Why during the second wave so many cases came in? So there are conjectures. And the first conjecture is that COVID primarily affects the upper airways. The epithelium gets denuded, its immunity goes down. So mucormycosis, being a ubiquitous organism, is affects the upper airways, and from there it penetrates. That's a simplistic explanation. There are some other, besides, I'll come to steroids little later, and diabetes, of course. Other thing which have been thought about is, funny things like, industrial oxygen being used. Few things about using dirty mask, not being washed for a very long time. But those things are actually None of them has got any evidence to prove that it occurs. The most important thing to my mind is the rampant use of steroids. And we all know that, steroids were used even at the outset when the diagnosis was made in the home setting, and sometimes the astronomical doses of steroids were used for a very long time. And new onset diabetes, which were not known. Some of our patients didn't know that they had diabetes, and when they were given steroids or when they were admitted to hospitals where sugars were 600, 700, 500. So that was one of the main thing. Another thing which I want to say that for reasons not known to us, COVID is a viral infection. It somehow suppresses the immunity. I mean, in a small hospital that I work with 200 beds, I saw 3 cases of amoebic liver abscess in post-COVID patients, which were diagnosed with some amount of difficulty because we kept focusing on hyperregulated syndrome. So I strongly believe that besides the steroids, which precipitated the diabetes, not only that, steroids we all know in critical care that they predispose a person to secondary infection. But rampant and over and misuse of steroids. But there are certain things which we do not know about the immune status which is compromised during the COVID. By virtue of that, we not only saw the mucormycosis, we saw other infections also. Other reason is overuse of antibiotics. We keep criticizing each other for overuse of antibiotics, but when the patient is on intensive care, he is on ventilator or whatever, I would admit that I always use, I mean, if you see my chart, majority of patients would be receiving antibiotics. One of the other factor which is a theoretical, is that use of voriconazole can also precipitate mucormycosis. So these are some of the conjectures. Diabetes is not in question, steroids is not in question. Still, there are some unanswered questions why the first wave did not see black fungus, why it was in the second wave, so many cases were seen. Probably the Delta virus, which hit the second wave, and this is my thought process without any evidence. The Delta virus probably killed the immunity of a person, and that's how it was so much more lethal. And that predisposed to COVID, there is no other explanation for mucormycosis than a specific virus affecting us. Thank you.
That was brilliant, Dr. Kilani, and especially your hypothesis regarding the Delta virus being the incriminating agent. That could lead to, at least a hypothesis generating a situation where we could do some experimental studies on that. That could lead to the answer to that. But maybe that is for the next panel discussion that we might have. I forgot to introduce you. You are a consultant pulmonologist at the PSRI hospital in Delhi. But you don't need any introduction. And you are obviously the head of the department and professor of pulmonology at All India Institute of Medical Sciences before that.
Thank you, Prakash.
And to add to that, all the other things being putting aside, you're a personal friend of mine. So I move on to another personal friend of mine, and that is Dr. Raj K. Mani. Dr. Raj K. Mani is, he has traveled most of the big hospitals in Delhi, and presently he is the director, strategy and COVID management, including critical care.
No, I'm now clinical director. Yeah.
You are the clinical director. Okay,
Yeah.
clinical director. Okay. At Vaishali Hospital in Ghaziabad. And I would
Yashoda Hospital, Kaushambi.
Yashoda Hospital, Kaushambi,
Ghaziabad.
Yeah. Okay. Yashoda, I'm sorry, really. Vaishali is Yashoda Hospital. Okay, my question to you is similar because you actually share the exalted position in critical care as Professor Kilnani does. So I would ask you a similar question as to what could be the reasons for the surge of post-COVID mucormycosis cases. Same question to you as well.
You see, I think, thank you for this great opportunity, Prakash, to share a panel with my very dear colleagues. The thing is, it calls for an introspection. We went initially for very self-defensive explanations, to be honest, because we have always known about mucormycosis. For 30 years, we know it is associated with diabetes almost invariably. It is associated with immunosuppression in the context of transplant, and particularly bone marrow transplant, and also with immunosuppression, cytotoxic agents. We've known this. There's nothing new. And we also know that opportunistic fungal infection, molds, are quite prevalent in the context of viral illnesses. We have seen that aspergillosis, invasive aspergillosis, was fairly common if you suspect it in the context of H1N1 pneumonia. In one study from Leuven, it was about 30% of cases where they found at least probable or definite aspergillosis. We also know in the context of critical illness from before that nosocomial mucor was possible even before COVID. Now, there are case reports published in ICM and other intensive care journals of mucor of the lung or mucor of the skin in the context of critical illness of various kinds. Variety of critical illnesses, lot of antibiotic therapy, antifungal therapy, voriconazole, as Professor Kelani pointed out, because that we have not studied this time round in all these registries and all these retrospectives. We have only superficially touched upon the antibiotic pressure and the selection pressure of voriconazole. All of them used empirically. Now we have pushed this empirical therapy to an extreme and we are seeing the collateral damage. Hit hard, hit fast has been cleaved to the chest a bit too much. And we have hit the environment, the ICU environment, hit the flora environment of the patient. So let us view it from that context. And to say that somehow COVID has some greater role to play than the usual conventional scenario of opportunistic infection is a little unacceptable, for the simple reason that of all the millions of COVID in the world, nobody has reported so many mucor cases. There is a WHO registry which has got 43,000 cases registered from I think April to June, right? 72% of them are Indian, assuming we have reported all of them. And there have been some 3,400 or so mortality, majority of RRs, overwhelming majority RRs. Now that is an eye-opener. The Delta virus has spread to 80 countries. Now, which other country has reported so many? There is something in our practice. Now, let us call a spade a spade. There was absolutely no steroid stewardship. Okay, we have talked a lot about antibiotic stewardship, never ever implemented sincerely in any of our hospitals. I have been to so many hospitals. I've tried to do it. The resistance of it is really alarming and impossible. Now, stewardship of steroid was even worse. I think we almost got a license after the declaration that steroids is the only life-saving drug that's proven, right? Now, it's proven in a small subset. It's not proven across the board. It's not proven the moment you diagnose COVID. It's not proven the moment you see a couple of little GGOs on the CT scan. Okay, it is not proven as a treatment of panic among the relations and the treating doctor. So we used steroids inappropriately, and I suspect if you look a little deeper into this data, you will find out at what stage the steroid would start it. That we do not know, right? We say the median use is 14 days. When? In the first 3 days of COVID, first 1 week of COVID, or later? There is something lurking there, information. We started it in the viral load period, okay, and we escalated it when they got admitted, and we used doses which were not at that point in time evidence-based. Okay, 6 milligram, at the most 10 milligram of dexamethasone for 5 days, and de-escalation was not followed. We followed it partially. We used this and prolonged it, or maybe doubled it. I know many people who use steroids just whenever the oxygen wouldn't go up. Okay, steroid as a monotherapy for hypoxia. All right. They would prolong the non-invasive ventilation. There was a phobia about invasive ventilation. And there was a belief that if you invasively ventilate anybody, the outcomes are bad. That were so, I think it's our invasive ventilation outdated.
I know you've got.
So I'll summarize in 2 lines. So
Okay.
I think there was inappropriate use of steroid, inappropriate use of empirical antibiotic therapy, and there was a lot of preemptive therapy of antifungals, and which we must look at seriously.
Thank you. That was also very enlightening. But I know you don several hats, and I would use your hat as an administrator. And I'll ask you similar questions on Mucor. Now, how did you ensure the relations of the COVID patients were kept informed about their loved ones? Because obviously the visiting and policies were almost non-existent, and but the relations were concerned as they would be. As an administrator, how did you manage to get the two together?
See, as an intensivist first, and then as an administrator, I place a lot of value upon communication. I tell you, there is so much of avoidable suffering in intensive care setting for which the intervention of communication is required, nothing else. So there has to be, after the rounds, some time allocated for family rounds. Okay. You do it face-to-face or virtually, does not matter. But virtually we did plenty, okay, through video calls or through Zoom platforms. I think the difficult communication has to be done and over with, particularly in the context of suspected mucor, because it's a very horrible thing to disclose, when it is too far gone. So the disclosure is very important, a quality measure for a physician in the intensive care, for any physician. But in the intensive care context, you can't plead that I don't have time. Sorry, it's an intervention as important as putting lines, okay, or intubate. It is not anything different.
Thank you, Dr. Murray. At least one thing that we can all learn from you is the empathy towards your patients. And that is something you always highlight all the time. And despite all that, I'm sure that we have to carry on doing this work because it will never end. Thank you for your really good insight about this. So I move on now from Delhi to Orissa. We have a friend there, Dr. Rekha Das. She is the professor of anesthesia at the Cancer Center of Cuttack, State Cancer
Yes.
Center in Cuttack in Odisha. And is she there? Are you there?
Yes, sir. I'm
Yeah,
there.
sure.
Yes.
So I know that you are right under the noses of the Odisha government. And that is why I asked you this question. What specific directives did you get from the state government to deal with the COVID-associated mucormycosis?
We were actually, regarding the medical part, we were all provided with the drugs by the government. The government was very supportive regarding supply of drugs, and there was no hesitancy or any difficulty in getting
My
them.
question was, did you receive any specific directives or specific guidelines from the government agencies to manage this?
That's what I'm saying. Regarding the medical part, we were very clear about the whole thing. Yes, we knew how to go about with the diagnosis with a KOH mount or to go with a nasal endoscopy or with a CT scan. The diagnoses were very much clear. They were put in place. The medical treatment was also put in place. But the surgical point, the surgical directives were not very clear cut because the density of this complication was not very high, was rather very low, very sporadic in Odisha. So government was not very clear cut about the surgical management of these patients, but there were instructions to the different departments like the ENT department, the neurosurgery department, but these were the basic 2 departments who were taking care of the complications if they arose the surgical part. And we were given the instruction that if anything happened, then we would be contacting them. But because and the number of patients who suffered from mucormycosis was very little. Hardly there is no clear-cut data actually how many suffered. There were only sporadic cases here and there reported from private hospitals, not from any government hospitals. Because as far as SCB is concerned or cancer hospital is concerned, we did not have any data regarding mucormycosis, incidence of mucormycosis in the hospital, although the number of patients were very high. And everyone was quite aware that such of the signs and symptoms that could happen. But so this was we did not have a clear-cut guideline regarding the surgical management. It was just given an instruction that if anything happened, we would be contacting our head and they would be taking care of the situation. And as far as private hospital is concerned, it was their individual lookout, because again, all the private and the government hospital had to work under government of Odisha. Whatever the government had taken up the thing so strongly that nobody could deviate, because all the private hospitals were also, they were being funded and they were being managed by the government hospital. The private they worked like a PPT. So they could not deviate from the main principle of treatment. So that was the basic. So I think some of the corporate hospitals, the way they managed was their independent way of managing. But basically the 80 to 90% of the hospital that were being controlled by the government, even the good corporate hospitals that were being controlled by the government, they also did not have any clear-cut directive about how to manage a mucormycosis. So I also work in a private hospital, but that was not being managed by the government. So we did have 3 cases of mucormycosis, 2 of which we operated by doing a nasal endoscopy, doing our routine, all those prerequisites we did to diagnose the case. But there was no clear-cut directive about the surgical management. There were only guidelines regarding diagnosing them, regarding because there were free service for diagnosis, there were free service for medical management. But about the surgical part, that was a big query. We did not have any guideline.
So I'll cut you short there. I'll ask you whether there was a shortage of these antifungal drugs, especially.
No, we did not have any. We did not have any shortage of antifungal. But by and large, I think in Odisha also as Sir Dr. Mani said, that our preemptive use of voriconazole was also not that high. It was not high. So probably that is one of the reasons why we did not encounter mucormycosis to such a great extent also. Because if it had been really that huge, large percentage, it would have really come to focus. It is not that people have hidden or anything, because everything was being followed up by the government. The number of cases, the number of drugs that are being used, they had to be updated, because you had to get it from the government store only. You could not get it from anywhere else. Even all the pharmacy and all even all the injections that came into Odisha were all controlled by the government. So it was not like you could go out of your way to procure drugs or anything. So basically the preemptive use of voriconazole or other antifungal were also limited. So that is why probably that is one reason why we had a good control over this deadly this fungal infection. Besides, of course, something like
Rekha,
steroid use at the practitioner level was not in our control. That out of that, many
I'll stop you there, Rekha.
Yes, sir.
I can only say that you are very fortunate, unlike all the other panelists in this discussion, including me, who were inundated by mucor cases in this April, and we are even now we are dealing with them. You are a bit fortunate not to get so many cases. So I'll take you back to COVID per se, and I'll ask you a question which is related to, let us say, a psychological aftermath or a sequelae of COVID. Now, lots of patients come with lots of vague problems after COVID. Some say that it is paining here, it is hurting there, and I'm not getting sleep during the day, and I'm getting nightmares and all that stuff. One question which has led to a lot of problems, especially in Delhi, is that patients are coming up with a lot of chest pain. And some of this chest pain is so sinister that they have landed up in the cardiac cath lab and got themselves angiographed also. So this is one thing which is causing a lot of concern, because quite often than not, most of this angiography is negative, and more often than not, the chest pain is related to the sequelae of COVID itself, because most of the lesions in the CT scan, as we see, have not resolved. And of course, there's a psychological component to the whole thing, because it is a stress and people have post-stress disorder. So have you come across this kind of patients, and how have you counseled them?
So this is rather an unsolved problem, I would say, at the present, because because people are going back to remote areas. They're going to villages, and we are getting phone calls from them regarding this kind of a complication or this kind of a discomfort or symptom. But government has helped them take the treatment, but the long COVID symptoms, and there is no protocol, or there is no, the numbers are so huge, and the numbers are so huge that it is beyond the government to go out and help these people, because people have been getting free treatment all throughout, and suddenly they would not like to go to a cath lab and get themselves tested or do a CT scan again and find whether it is due to lung fibrosis or it is due to some other just a feeling of discomfort that persists for a long time due to prolonged hypoxia or a delayed resolution of ground glass opacity, that we are unable to say, because again they would have to pay from their pocket. And once patients start getting free treatment on their own, they would not like to come back if they can manage without it. So this part is quite unsolved in our part. But my private patients, they do come. And when they come, we get them tested. We put them into all kind of basic cardiology tests, and if necessary, we put them into we do a CT scan on them, and then we treat them accordingly. But it's not like they're going straight to the cath lab. In our place, at least, it has not happened.
Thank you for being such a candid person on that front, because these psychological problems could be a discussion point for a separate panel discussion. It is such a vast topic, but I thought that in that part of the country where things are not so much highlighted by the media as we see in Delhi, but I'm sure that people have the same kind of problems, and these problems are persisting, and we really don't have any answer to them. And only thing is that we can only tell them that you bear with it for some time, and hopefully in due course of time it will go away. So thank you very much for being part of this panel discussion. I will move on.
It's a wonderful opportunity.
Thank you. I'll move on to a very close friend of mine, Ashit Hegde, right from Eastern India down to the absolute Western coast, Mumbai. Hinduja Hospital, Mumbai. He's a consultant physician there. And here, again, the same type of questions I have to ask. Ashit, how as an institution did Hinduja come together to handle mucormycosis in its various shapes and forms?
Well, actually, ours is a medium-level private hospital, and we really didn't have the deluge that the large teaching hospitals and some of the larger private hospitals had. In fact, actually, in-house, none of the patients admitted to our own hospital with COVID ever got mucormycosis. Everybody who came to us with mucor was referred from elsewhere, most of them from northern Maharashtra. So we were sort of prepared when they came, and we never really had the deluge. At the most, in a week, would probably have 10 or so. That's not really you can't really call it deluge. So it was not really very difficult to deal with these patients. And honestly, in a private hospital, you really can't form dedicated teams, because each patient has a right to select his ENT surgeon, his ophthalmic surgeon, his neurosurgeon. So we really can't force them to go to a particular team. But if given the choice, yes, we had certain people who were preferred for these things, but that is provided the patients agreed. But if the patients wanted somebody outside the team, we had no choice. We had to respect their wishes. Honestly, I mean, now in my age, I'm trying to old age. Hello?
Come on, Ashit, you can't go old.
No. What I'm trying to say is that I'm trying to release my stress. So most of my patients admitted under me really was referred to the ID. And honestly, as a physician, because the infectious disease, we have a very good infectious disease team in our hospital, and they were managing most of the the medical aspects. Because I think I thought this is the patient's interest that dealt best with the the ID physician. If there was any intensive care problems, of course I looked into them. But my role as a physician actually was in the background. I really asked ID people to look at them, and like you said, that they had a dedicated opthal and a ENT person, but if the patient wanted somebody else, we call them, we respect their wishes. One thing about the eye, at least the ophthalmology colleagues tell me that this time, actually, as compared to the the non-COVID mucormycosis, they were able to save a lot of eyes. Like a lot of people who would have ended up with the enucleation in the past, actually they could save. If the vision was preserved, many of these people, they could able to save the eye. They felt that this particular form of mucormycosis for some reason was not as invasive, was not as aggressive. It gave you time. So they felt, in many patients, actually, they could save the eye, which was a little gratifying. Like you said, many of these people probably a year ago, 2 years ago would have lost the eye. But this particular, that's what they claim, that you could, try and save the eye in some people, and many patients have succeeded in saving the eye. Because it was not as aggressive as the non-COVID strains of mucor. That is just an experience from some of the surgeons in our hospital. I don't know the other hospitals have the same experience.
Ashit, I know I'm being unfair, but I have to ask this question. When you talk about saving the eyes, definitely there were patients where the orbital extension had happened, but there were occasions in which the eye as a whole was saved. So, but if there was an involvement, how did they take care of debriding the orbit? Was there some alternative that they did? Did they do some innovative surgeries? Did they go for peribulbar installation of amphotericin B? Those kind of things. I'm sorry. I mean, I know it's not your domain, but in
No, but you're right. They instilled that much. I know they instill amphotericin locally. That much I know that they instill amphotericin locally. Like you said, they say the technique. They said they gave you time. Like otherwise, in the conventional mucor, if you don't do the enucleation, in one day it's all over. But here they said they could do repeated debridements and watch and see, because it was not that they had to. It was not progressing that rapidly as the the non-COVID associated mucor. So they probably could do it stepwise. Not that everybody's eye was saved, but some people, like you said, but they did instill local amphotericin. That's something that I know. Other surgical techniques, honestly, it's not my domain, and I did not really. But they instill amphotericin locally. That much I know.
Similar to Dr. J.V. Peter, I really appreciate and hats off to your ophthalmologist who were brave enough to not to go for exenteration, because that is the easy way out, as you put it. But it is more difficult to really try and save the eyes. And obviously it meant more hard work, maybe more expenses to the patient, because they would have to undergo several more MRI, contrast MRI with their
Look at surgery, etc. You're right, but then if it's worth saving the eye, it's probably worth the expense.
Absolutely, absolutely. So again, the same question that I've asked to other panelists also, and this is again related to ophthalmology, I would say. How did you find it difficult to convince the patient to undergo mutilating surgery? I know number one is the mutilating surgery. Number two is the money involved to undergo all these operations. So obviously there was a bit of difficulty there, I would say.
See, to some extent, it was not that, it was difficult, of course, but people have been referred to us. It's not that people came, they were not patients already in our hospital. So they have come referred to some other centers. So to some extent, they were prepared. They're coming to a corporate hospital in Mumbai. And so they, to some extent, were prepared for because the physicians who were referred them obviously had prepared them. We also have I mean, in most patients you could not afford, we obviously try to use posaconazole as compared to other isobuconazole and ambisome. Of course, after some time it was out of our hands because neither ambisome or isobuconazole available, so we had to use posaconazole in everybody. Also in our hospital, fortunately, there's some system of charity. So many patients, obviously almost everybody eventually, got some kind of charity. And to some extent, even the rates, at least, in treatment charges were fixed by the municipal corporation, even in the private hospitals. So lots of, so most of them, they were getting treatment almost at municipal hospital rates during the COVID epidemic, so I mean, I still, of course, given the cost of what killed them really is the cost of the drugs. So with posaconazole came down a little, but other treatments, like I said, cost was now after, because the municipal corporation had limited costs in even the private hospitals. It was bad for the hospitals, but probably was good for the patients. So, and after that, of course, we still had a system of charity. So we tried to manage. Of course, even in spite of that, many patients found it beyond their means. Some of them.
How real was the shortage of amphotericin B during that period, and how long did
it was very, very real, and it was rationed. All the amphotericin isobuconazole was with the municipal, under the control of the municipal corporation. So we had to go to KM hospital to get a stock. It was like rationed out. So each one had to go to, if I wanted it, we had to go to the KM hospital. It was strictly rationed out, with details of the patient, etc. It was probably we were getting only 2 or 3 doses per day, or 2 or 3 days doses each time. So each time the patient relatives had to go there and get it. If it was available, they would get it. If not, we had to use posaconazole. But ultimately, it was too much of a hassle, so we ended up using posaconazole in everybody.
Oh, great. So you ended up using azoles in this patient. It was a similar problem in our hospital as well. If we had to have amphotericin B, then we had to fill up a form, and that form would be ratified by a nodal officer nominated by the government of Delhi. And then after his permission only, and the permission would come through either if the KOH is positive or if the CT scan is very suggestive. Otherwise, it will not come through. So we had our own set of problems, but there was a lot of gray market available. And so people could manage to get amphotericin B from the gray market. Of course, they had to pay a lot of money for that. But we did manage to get our usual supply. Those patients who were in the intensive care unit, somehow or other, and we do keep a stock of amphotericin B in the hospital, it's in the ICU itself, which is given free of cost. So we could manage to supply at least during the period when we did not get the supply from the government. So that intervening, there were some dose, as you said, 2 or 3 days was given to us. So sometimes the next lot would come only after 4 days. So that 1 day gap would be catered to by our own things. Anyway, so this was a great eye opener, and it was indeed a huge privilege for me personally, and all the panelists that I had to moderate. The job was made easy because number one, they are personal friends of mine, and we have been on several occasions, on several conferences together. So the bonhomie was there, and but then despite all that, I have to
Prakash,
admit
one
that
question
a
to my
few
colleagues
certain
and
aspects.
yourself.
Absolutely.
Now,
Great.
why couldn't we use the plain amphotericin B pending your getting your ambisome? Because I'm not seen as study or a trial or head-to-head which compares that is found to be less efficacious. It could be more toxic, but you can manage that with careful titration of dose and usage. And it is far less expensive. Many people will get devastated economically by the use of 5 to 10 milligram per kg of ambisome.
I would agree with you. We have actually done that. As I told you, there were occasions in which we did not get the regular supply from the government, and we have fallen back to our own stocks, in which deoxycholate salt was the one which was the most commonly available. So to tide over that period, we have used amphotericin B deoxycholate. I would completely agree with you that as far as efficacy is concerned, it is the gold standard, and it will remain the gold standard. So I don't hesitate to use it, because at the end of the day, you want a living patient and not a living kidney in a dead patient. So very clear that amphotericin B deoxycholate, if I have to give it, I would definitely give it. But across the various guidelines, the drug of choice is liposomal amphotericin B, and that is why probably you are more right if you're using liposomal amphotericin B than if you. But if you have to give something and you end up not giving anything, better than not giving anything is amphotericin B deoxycholate, and as you said, a 50 milligram dose would be sufficient for most of the patients
So
that come. Yes, yeah.
if I could come here, it's not that amphotericin deoxylate is less effective than liposomal or any kind of amphotericin. It was not available. And only thing is that your monitoring has to be more with conventional amphotericin B. The dosages you can push in are slightly less. Kidney damage, if at all, is reversible. So I totally agree with Dr. Mani. I think there was no hesitation on part of any physician not to use amphotericin deoxylate. It was not there. That was the problem. It was not available.
I think I'm completely out of time now, so I'll have to take leave from you, and thank you very much for that enlightening panel discussion. And I must say, with due humility, that I have learned as much as possibly I've probably told you people, and maybe what you have derived from my PowerPoint presentation. So really, thank you very much from the bottom of my heart. Thank you.
Thank you all.
Thank
Bye,
you.
everyone. Thank you.
Thank you all for such an interesting session. I would now request Dr. Rabia to come over and carry over the next session. Good afternoon, everyone. Taking this enlightening session forward, we begin with our first thematic session of the day. The chairpersons for this session are Dr. Arvind Yadav, Chairman, Shri Krishna Hospital, Agra; Dr. Rajesh Gupta, Pediatric Surgeon and Principal, Autonomous State Medical College, ETA; Dr. Vaibhav Bhargav, Consultant in Charge, Medical ICU and Emergency, Eternal Hospital, Jaipur; Dr. Praful Arya, Senior Consultant, General and Minimal Access Surgery, SPS Hospital, Ludhiana. Lightning session forward, we begin with our first thematic session of the day. The chairpersons for this session are Dr. Arvind Yadav, Chairman, Shri Krishna Hospital, Agra;
Dr. Rajesh Gupta, Pediatric Surgeon and Principal, Autonomous State Medical College, ETA. Dr. Weber Bhargav, Consultant. I have one small announcement here that Dr. AP Singh will not be able to join us for the session due to some technical difficulty. So I would request Dr. Arvind to kindly introduce our first speaker for the session. Good afternoon, everyone. Taking this enlightening session forward, now we begin with our first thematic session of the day. The chairpersons for this session are Dr. Arvind Yadav, Chairman, Sri Krishna Hospital, Agra; Dr. Rajesh Gupta, Pediatric Surgeon and Principal, Autonomous State Medical College, ETA; Dr. Weber Bhargav, Consultant in Charge, Medical ICU and Emergency, Eternal Hospital, Jaipur; Dr. Praful Arya, Senior Consultant, General and Minimal Access Surgery, SPS Hospital, Ludhiana. Taking this enlightening session forward, now we begin with our first thematic session of the day. The chairpersons for this session are Dr. Arvind Yadav, Chairman, Sri Krishna Hospital, Agra; Dr. Rajesh Gupta, Pediatric Surgeon and Principal, Autonomous State Medical College, ETA; Dr. Weber Bhargav, Consultant in Charge, Medical ICU and Emergency, Eternal Hospital, Jaipur; Dr. Praful Arya, Senior Consultant, General and Minimal Access Surgery, SPS Hospital, Ludhiana. Taking this
Good morning, ladies and gentlemen. Thank you, Mr. Chairman, for the kind introduction. I would like to thank the organizers for inviting me to be a part of this wonderful event. It's an honor and pleasure to be a part of this conference. Thank you all for joining this session this morning. My topic is on the therapeutic protocol that we use in our ICU for COVID-19 patients. I have no conflicts of interest for the purpose of this talk. And these are the objectives I hope to cover in the next 12 to 13 minutes. I'm basically going to go over what we use, why we use, and how we use it. We've gone through about 3 waves of COVID so far, and of course, our protocol has changed and evolved based on the evidence that has emerged and also based on our experience. So right now, it's fairly simple. We use corticosteroids like everyone else does. We use prophylactic anticoagulation for all our patients. We do monitor D-dimer levels on a daily basis, not to initiate therapeutic anticoagulation, but to guide us to look for presence of thromboembolism. We do use tocilizumab very, very selectively in our patients. We don't use routine empirical antibiotic therapy. And we do use vitamin C and vitamin D as adjunctive therapies in these patients. What we don't use and we've never used is any form of antiviral therapies. We've not used any other form of immunomodulators except steroids and tocilizumab, including convalescent plasma and monoclonal antibodies. Now, coming to corticosteroids, you all agree now it's a standard of care for all patients admitted to hospital with COVID-19 to receive corticosteroids. Now, up until the beginning of the first wave, we used methylprednisolone at a dose of 1 milligram per kilogram for about 5 days. We used that until the recovery trial was published. And once that was published, we actually adopted the same protocol and we used dexamethasone routinely in all our patients at a dose of 6 milligrams per day for 10 days or until they're discharged from the ICU or hospital, regardless of the type of support that they get actually, whether they're on high flow nasal cannula or NIV or invasive mechanical ventilation or ECMO, they get the same dose and the same duration. We do use hydrocortisone if the patient subsequently becomes septic, and then we use the same low dose hydrocortisone as we use in septic shock patients as well. Why we use steroids? We know that SARS-CoV-2 induces significant inflammation, and we know that steroids have significant anti-inflammatory effect with a non-specific immunomodulatory effect on the inflammation. Most of the data and evidence comes from the recovery trial. And this was, as I'm sure you're all very, very familiar with it, this was a randomized multicenter trial that enrolled over 2,000 patients that were randomized to receive either either dexamethasone or standard of care. And as you can see in this Kaplan-Meier curve, there's a clear mortality benefit at 28 days in those patients who received dexamethasone. And this benefit was much higher in patients who are on invasive mechanical ventilation and those who are on oxygen therapy. Subsequently, a meta-analysis was published in JAMA, which included 7 randomized controlled trials, and the recovery trial was one of them, and that actually contributed to most of the data and most of the patients. The meta-analysis included studies that used different doses of steroids, different duration, different types of steroids, but nonetheless, you can see there was a significant mortality benefit with the use of steroids, and low-dose steroids were as effective as high-dose steroids without significant adverse effects from both. Moving on to tocilizumab, we know that it's an IL-6 receptor monoclonal antibody. It basically blocks the binding of IL-6 to receptors and therefore blocking IL-6 signaling and subsequent inflammation, mainly used in patients with rheumatoid arthritis and some forms of cytokine release syndrome. The rationale for using in COVID-19 patients is that IL-6 levels are thought to be higher in these patients and are linked to the cytokine storm that occurs in these patients. So our practice, we basically use in very selective patients. We don't give it if the patients are admitted have been in the hospital for more than 48 hours. We only give to patients who are in the hospital for less than 48 hours, and those patients who are high flow nasal cannula or NIV. Once they're tubed, we don't give it to them. Usually, a majority of the patients, we only give one dose. We've never given 3 doses. At most, in about 10%, 20% of the patients, we've actually given the second dose. The rationale being, there have been so far about 8 randomized controlled trials that have been conducted on tocilizumab, and pretty much all of them have used similar doses, 8 milligram per kilogram. All of them have included patients within 10 days of symptom onset or within 48 hours of hospital admission. And all of them have pretty much included severe to critical illness, except the last one, which is basically where they've included mechanically ventilated patients. And if you look at the results, the outcomes have been indeterminate, both for primary and secondary outcomes. And if you look at the 2 trials based on which majority of the hospitals have adopted the use of tocilizumab in their patients, the outcome has been pretty positive both for primary and secondary. But if you carefully look at the details of the study, more than 80% of the patients in these trials have received steroids, and therefore questioning whether it's the effect of steroids that we're seeing or is this the tocilizumab effect. And if you look a little bit more carefully at the recovery trial, those patients who received NIV or invasive mechanical ventilation, there was no difference in mortality whether you received tocilizumab or not. And again, questioning, should we be using tocilizumab in these group of patients? And again, the recovery trial showing those patients who received steroids had the highest benefit, again, questioning the use of tocilizumab in this group of patients. For me, one of the biggest challenges is, when to give it and which group of patients you give it. It's very clear that it's more beneficial if you actually give it at the peak of the inflammation, but how to identify, we don't have clear parameters. I know the recovery trial used CRP of 50 and above. Pretty much every patient admitted to hospital, even on the regular wards, has a CRP of 50 and above. So that's not an ideal indicator. Maybe an IL-6 measurement would help in picking up the right patients. So definitely useful in severe to critically ill patients. Luckily, there's no difference in infection rates in both groups, despite the occurrence of significant neutropenia in this group of patients. Moving on to anticoagulation practice, we know that COVID-19 is a very prothrombotic disease. The incidence of thromboembolism is very high compared to the non-COVID ICU population. PE seems to be more common, predominantly affecting small to medium-sized vessels, suggesting more of an in situ thrombosis from immune-related thrombosis rather than the usual virtuous triad-related pathology. And it can occur even in the absence of DVT or prophylaxis. And so because of the high incidence, most of us have been actually using, intermediate to therapeutic dose anticoagulation in these patients. And that's what we've been doing up until about a couple of months ago, where we've actually changed over to using low molecular weight heparin in all our patients unless there's a contraindication. However, we do use a slightly higher dose than prophylactic dose for our obese patients, and this is our practice even in non-COVID patients too. We don't use novel anticoagulant agents in the in-hospital setting. For those patients who have thromboembolism, we follow the same protocol as for non-COVID patients. Why? Because the incidence of bleeding with therapeutic anticoagulation is higher, particularly from the non-CNS and the non-GI sites, and it is associated with a higher incidence of in-hospital deaths. A recent study published, which is a huge collaborative study from REMAP-CAP, the ACTIV-4A trial, and the ATTACK investigators, which was a massive multi-center randomized controlled trial comparing therapeutic to prophylactic anticoagulation, showed no difference whatsoever in terms of survival to hospital discharge or organ support. Again, questioning the rationale for using therapeutic anticoagulation. So we should all just stick to prophylactic anticoagulation unless there's a clear evidence of thromboembolism. But what we do is we do use monitor D-dimer levels on a regular basis, not to start therapeutic anticoagulation, but to help us look for evidence of thromboembolism. If the D-dimer levels are elevated, we do actively look for VTE, and that may trigger us to do a CTPA, for example. And usually the cutoff levels have been shown to be anywhere between 1,000 to 4,800 micrograms per liter. Now, moving on to empirical antibiotic therapy, like most of us across the world, we did use empiric antibiotic therapy in the form of ceftriaxone and azithromycin for about 3 to 5 days in all our patients. However, since the beginning of this year, we've changed the practice based on evidence, as well as the fact that we've experienced increasing number of MDROs in our patients. So we've stopped using routine empiric antibiotic therapy. But what we do is we do send cultures upon admission for all patients. We closely monitor, and if there is any suspicion of bacterial infection, i.e., procalcitonin going up, or if there's a dense consolidation in chest X-ray, we start them on antibiotics. Why? Because less than 4% of patients with COVID-19 have bacterial co-infections, and therefore it's not worth exposing the remaining 96% of the patients to empiric antibiotic therapy. The other reason for not doing that is also because it increases the risk of hospital-acquired infections. In particular, MDRO rates are very high in this group of patients. And if you look at the risk factors, those patients who receive antibiotics in the first 48 hours are at increased risk of getting hospital-acquired infections in addition to dexamethasone. We do use simple things like vitamin C. We know it's a fantastic drug. It's an antioxidant. It's a free radical scavenger. It has anti-inflammatory properties. Most of the evidence for it comes from studies involving sepsis and septic shock. Unfortunately for COVID, there are no big randomized controlled trials. Most of the data is based on small retrospective and pilot studies. So we don't use high-dose vitamin C. We do use just 2 grams per day of vitamin C. Vitamin D, again, an amazing anti-immunomodulatory hormone drug, whatever you call it. The reason why we use it is vitamin D deficiency is highly prevalent in the UAE, approaching up to 90%. There's no strong data to support its use for COVID-19 patients, but we use it because of the high prevalence of deficiency. So take-home message, keep it simple. Steroids are standard of care, and it's the only therapy that has the strongest evidence to date. We limit tocilizumab to patients who've been in the hospital less than 48 hours, and those patients who are on high-flow nasal cannula and oxygen therapy. We use prophylactic anticoagulation now, not therapeutic anymore, and we do not use routine empirical antibiotic therapy. And thank you for your attention.
Thank you, ma'am, for your valuable input. Now I request Dr. Rajesh Gupta to kindly introduce our next speaker for the session.
Hello. Hello. Can you hear?
Sir, I request you to introduce our next speaker for the session.
And thank you for your attention.
Okay. So the next speaker for the session is
Thank
Dr.
you, ma'am,
Yash.
for your valuable input. Now I request Dr. Rajesh Gupta to kindly introduce our next speaker for the session.
Good morning, good afternoon, and thank you for inviting me to chair this session. Our next speaker is Dr. Yash Yaveri. Can you hear? Hello, can you hear? Hello.
Yes, sir. Yes, sir.
Yeah. Our
Sir, I
next speaker
request
is-
you to introduce our next speaker for the session.
Thank you for your attention.
Okay. So the next speaker for the session is
Thank
Dr.
you, ma'am,
Yash.
for your valuable input. Now I request Dr.
Sir, it is some technical glitch. We'll just sort it out, sir.
Speaker for the session.
Good morning, good afternoon, and thank you for inviting me to chair this session. Our next speaker is Dr. Yash Yaveri. Can you hear? Hello, can you hear? Hello.
Yes, sir. Yes, sir.
Yeah.
Sir, I request you to introduce our next speaker for the session.
Thank you for your attention.
Okay. There is some technical problem. Actually, the audio is going too late.
Thank you, ma'am,
Basically.
for your valuable input. Now I request
Sir,
Dr.
it is some technical glitch. We'll just sort it out, sir.
Speaker for the session.
Our next speaker for the session is Dr. Yash Yaveri. Thank you for head of the critical care and emergency residency super specialty hospital Lucknow. Yash Yaveri, and he has been past chairman of the SCCM Delhi here.
Yes,
and
sir.
conveyor
Sir, I
of the.
request you to introduce our next speaker for the session.
Thank you for your attention.
I don't know what is the problem. Actually, the audio is going too late.
Thank you, ma'am,
Basically.
for your valuable input. Now I request
Sir,
Dr.
it is some technical glitch. We'll just sort it out, sir.
Speaker for the session.
Our next speaker for the session is Dr. Yash Yaveri. Thank you for head of the critical care and emergency residency super specialty hospital Lucknow. Yash Yaveri, and he has been past chairman of the SCCM Delhi here.
Yes,
and
sir.
conveyor
Sir, I
of the.
request you to introduce our next speaker for the session.
Thank you for your attention.
I don't know what is the problem. Actually, the audio is going too late.
Thank you, ma'am,
Basically.
for your valuable input. Now I request Dr.
Sir, it is some technical glitch. We'll just sort it out, sir.
Speaker for the session.
Our next speaker for the session is Dr. Yash Yaveri. Thank you for head of the critical care and emergency residency super specialty hospital Lucknow. Yash Yaveri, and he has been past chairman of the SCCM Delhi here.
Yes,
and
sir.
conveyor
Sir, I
of the.
request you to introduce our next speaker for the session.
Thank you for your attention.
I don't know what is the problem. Actually, the audio is going too late.
Thank you, ma'am,
Basically.
for your valuable input. Now I request
Sir,
Dr.
it is some technical glitch. We'll just sort it out, sir.
Speaker for the session.
Our next speaker.
Can I request Dr. Yash Javeri to start the lecture?
Head of the critical care and emergency residency super specialty hospital Lucknow. Yash Yaveri, and he has been past chairman of the SCCM Delhi here.
Yes,
and
sir.
conveyor
Sir, I
of the.
request you to introduce our next speaker for the session.
Thank you for your attention.
I don't know what is the problem. Actually, the audio is going too late.
Thank you, ma'am,
Basically.
for your valuable input. Now I request
Sir,
Dr.
it is some technical glitch. We'll just sort it out, sir.
Speaker for the session.
Our next speaker.
Can I request Dr. Yash Javeri to start the lecture?
Head of the critical care and emergency residency super specialty.
Technical team, please start the recording of Dr. Yash Javeri, please.
SCCM Delhi here.
Yes,
and
sir.
conveyor
Sir, I
of the.
request you to introduce our next speaker for the session.
Thank you for your attention.
I don't know what is the problem. Actually, the audio is going too late.
Thank you, ma'am,
Basically.
for your valuable input. Now I request
Sir,
Dr.
it is some technical glitch. We'll just sort it out, sir.
Speaker for the session.
Our next speaker.
Can I request Dr. Yash Javeri to start the lecture?
Head of the critical care and emergency residency super specialty.
Technical team, please start the recording of Dr. Yash Javeri, please.
SCCM Delhi here.
Yes,
and
sir.
conveyor
Sir, I
of the.
request you to introduce our next speaker for the session.
Thank you for your attention.
I don't know what is the problem. Actually, the audio is going too late.
Thank you, ma'am,
Basically.
for your valuable input. Now I request
Sir,
Dr.
it is some technical glitch. We'll just sort it out, sir.
Speaker for the session.
Our next speaker.
Can I request Dr. Yash Javeri to start the lecture?
Head of the critical care and emergency residency super specialty.
Technical team, please start the recording of Dr. Yash Javeri, please.
SCCM Delhi here.
Yes, sir.
Conveyor
Sir, I
of the.
request you to introduce our next speaker for the session.
Thank you for your attention.
I don't know what is the problem. Actually, the audio is going too late.
Thank you, ma'am,
Basically.
for your valuable input. Now I request
Sir,
Dr.
it is some technical glitch. We'll just sort it out, sir.
Speaker for the session.
Our next speaker.
Can I request Dr. Yash Javeri to start the lecture?
Head of the critical care and emergency residency super specialty.
Technical team, please start the recording of Dr. Yash Javeri, please.
SCCM Delhi here.
Yes,
and
sir.
To introduce our next speaker for the session.
Thank you for your attention.
Thank you for your valuable input. Now I request Dr.
Sir, it is some technical
kindly
glitch. We'll
introduce
just sort
our
it out.
next speaker for the session.
Can I request Dr. Yash Javeri to start the lecture?
Technical team, please start the recording of Dr. Yash Javeri, please. Yes, sir.
To introduce our next speaker for the session.
Thank you for your attention.
Hello everyone, thanks for the opportunity. I am going to discuss about non-COVID ICUs during the massive resource cut during the COVID pandemic. I have no conflict of interest or a financial disclosure to be made for this presentation. Remember, the guidelines which are local and nationalized has to be followed. The learning objectives, both COVID and non-COVID ICUs were hugely demanding and they had some intricate differences in administration, human resources, supply chain management and logistics were a major issue. Communication amongst teams and family communication both were a major issue, and we have done some nitty-gritty changes which we'd like to enlighten in the presentation. Resource sharing and networking were very, very important. Variable demand supply, and most of the time inadequate supply was the biggest challenge which we faced during the pandemic. Critical care is not a location, it is a process. It takes place not only in the ICU but everywhere. And during a pandemic, when we had surge of patients, we cannot rely only on critical care resources. We have to strengthen our non-critical care resources so we can avoid admissions to critical care areas. There could have been some vague definitions of ICUs during the peak of pandemic. COVID ICUs were confirmed or presumptive cases were taken. Generally, these were confirmed RT-PCR. Non-COVID ICUs, negative patients, negative by RT-PCR. Screening areas, screening emergency departments, screening as do most of them were looking like a critical care unit. They had patients of ILI or transfer from other facilities when the report for COVID was pending. And we had some areas which were like expandable ICUs, which converted general ward, we converted HQ, daycare into ICUs, depending on the staff pool. Silent ICUs. We had some pool areas which we converted into COVID or non-COVID, depending on the demand for particular subset of patients. Bottom line was more effective ICU trials. We have to screen patients not only with RT-PCR but also clinically for presence or absence of COVID signs. It was difficult to sectionalize, especially when manpower was constrained between COVID, non-COVID, especially smaller hospitals. This was a bigger issue. It has to be done as per resources and on PRN basis. We cannot have a fixed formula. It was ever changing and we were always breaking our heads during the peak. Zones and divisions, we tried to have very, very strict divisions of area, but it was not easy to follow that. And there were some overlap areas where we had mix of patients, especially the screening areas. They had both COVID and non-COVID. Unless they were diagnosed positively or negatively, they stayed in this screening area. We followed a very, very open-minded and pragmatic approach. Pragmatic solutions that can be achieved at relatively low costs. We had huge demand. This helped us to improve our collective and individual response, not only for this channel, but also for further similar challenges. The response to any disasters follow the basic tenets of disaster management: prevention, preparedness, response, and recovery. And these four basic tenets will apply to non-COVID areas also. Indeed, the best way to handle a surge of ICU patients is to avoid one. So we followed the same, especially during the first wave. We tried to reduce demand at downstream bottlenecks. We expanded our proactive management of patients at high risk of needing acute or inpatient services. Patients who are chronically ill, they had to have better care, so they do not need acute interventions or ICU care. reduce potential future spikes in demand on EDs and inpatients bred from non-COVID patients. Digital engagement and multidisciplinary virtual rounds were must. We have to keep the non-COVID ICUs and medical services open. Restrict elective ICU services used. Keep non-COVID facilities running. If we do not get the basic right care, non-critical care, obviously these patients will get sick and require an ICU care. A perilous deferral of needed service will lead to later acute hospitalization, which will in fact increase the burden on ICU. Proactively manage patients without COVID-19, particularly those with time-sensitive and medically complex conditions. This is important not only to sustain health and life, but to preserve future hospital capacity also. The demand was very, very variable, especially in non-COVID areas. During the first wave, we had almost no non-COVID patients. Second wave, 20 to 30% were non-COVID. So it was a very, very variable demand. So how much of manpower and machines to be given to non-COVID or COVID was always a challenge, and we were fighting this on a daily basis. Non-COVID ICU showed a significant reduction in the median number of admissions to the ICUs as compared to the pre-pandemic period. This reduction was most prominent during the intense lockdown phase. We also noted an increase in the median aperture to score and a significant decline in the ICU turnover. So these were sicker patients in non-COVID ICUs and they were staying longer with us. There were many other issues. Bed is a perennial issue and it's a very, very difficult ICU resource. Structure can still be faster, but trained power cannot be faster. Whatever could go wrong has gone wrong during the second wave. Mitigation of demand for ICU must be weighed against the feasibility of suppression of interventions and drawbacks of the intensity and duration of lockdown. Triaging has to be very, very strict. Principles of ethics, especially we should be very, very vigilant about end-of-life care policies. We should not be prolonging patients, especially when patients are dying because of lack of critical care. Engineering controls were variable. They require time. However, non-COVID areas also require similar engineering control as in COVID areas. Non-COVID areas, in fact, were a bigger challenge. Healthcare providers were taking that area easily. And they were acquiring more of COVID from non-COVID facilities rather than COVID facilities. Large number of non-COVID area patients were turning positive. There were outbreaks, there were cases of hospital-acquired COVID, and the intensive infection control measures were often not as strict as in COVID ICU. Sectionalizing COVID and non-COVID was a big challenge. We had similar staff, but we have to manage two parts. And the staff was not going from one area to other. There was myriad presentation of COVID. Could it be COVID? It could present as stroke, it could present as GBS, it could present as diarrhea. So many of our patients were landing in non-COVID and after a few days were turning positive. Delayed diagnosis, outbreaks. There were HR issues, insecurity amongst healthcare providers, sickness for the providers, for their family members, financial issues, PPE availability, especially during the first week. There are many, many fears. Some were placed, some were misplaced. Burnout because of variable reasons. Poor outcomes of patient was one. Healthcare providers getting sick and their death was another major issue for burnout. Stay, transport, F&B issue for healthcare providers were other major challenges. So we needed basic groundwork and planning. You have to know the magnitude of the problem. And it was variable depending on area. So you have to know your local dynamics. To know your resources, better undercount them. Give some place for sickness, for emotional burnouts. Resource distribution has to be dynamic based on daily, in fact, often on 8-hourly basis. Keep your herd safe. Testing protocol was variable, when to test. And COVID and non-COVID areas, especially the ICUs, were often gray zones. At the end, we needed workable solutions which are flexible. We realized minimalistic approach, non-COVID or COVID, less is more. The art of medicine was rejuvenated. We were back to basics. Good thing which happened, critical care was leading from the front. It was like a resource limited setting. We were not having many specialists coming into the COVID or non-COVID ICU. So we were really the jack of all trades. expandable ICU bed capacity, which could be sectionalized, which could be easily partitioned, was the key for faster turnover of ICUs. Safe ICU design, digital transformation, expandable ICU staffing pool, efficient supply chain management. These were major issues. Flexibility was required not only from HR point of view, but also from facility management and supply chain management. Strategies for relaxing or tightening ICU admission discharge criteria. We had command centers, we had a nodal officer in each hospital which was looking, HR was actively involved in all these issues. We had centralized approach. We have zones in the city where they were sharing their COVID as well as non-COVID ICUs. Obstetric ICUs, they were dedicated obstetric ICUs in the city. They were dedicated GI ICUs. So we tried to sectionalize and share resources amongst the hospitals also. Centralized command centers facilitate distribution of patients as well as resources from overloaded hospitals to hospitals with lesser load. The importance of a coordinated system-wide approach with input from all stakeholders could not have been more emphasized than during the second wave. There were collateral impact of COVID-19 on acute care of non-COVID patients, often called as COVID collateral damage syndrome. There were many reasons: fears, PPE availability, non-immunized status. These were the major issues behind this CCDS in the first wave. There were financial challenges, not only to the healthcare providers, but to the administrators also. PPE cost, structural cost, additional support, more manpower, low revenue, and a demand supply mismatch were the major issues. Communication amongst team as well to the patient was suffering. We often had newer teams whom we have never talked to. So distant communication techniques and skills were adopted freely. WhatsApp came handy. Emotional support was required not only for the patient and family, but also for the healthcare providers. We had many changes to our routine working. We shared resources. The care was often not that optimal, but there was continuity of care. Family was communicated often virtually with an electronic interface. Spiritual care, social care workers were involved digitally. And there were various other models which were required to decrease the emotional injury, not only for the patient, but also for healthcare providers. Buddy system, we are buddy to each other, and team dynamic principles were very important during this. Each hospital developed an inventory of supplies and equipment. Supply chain management was very important. Anything could go short during that peak of the pandemic. Shared resources was one lesson which we learned. We had common resources amongst chain of hospitals, amongst different zones in the city, and often between the states. Common pool of inventory, common pool of HR personnel. We were tracking continuously on shortage and items, and the communication was again very important. Networking between ICUs, regional PPP models, and networking with other stakeholders, especially administrators and allied fields in the care process. Transitions were difficult. How to make a ICU to COVID to non-COVID or vice versa. So flexibility was the key, flexibility in the partitions. Transition of patient and staff from one area to other was another gray zone. So the practice points, COVID-19 pandemic should lead to transformative challenges in how we provide critical care. These include improved ICU bed capacity and design, flexible ICU staffing, reliable supply chains for PPE, ICU devices, consumables, and pharmaceuticals. ICU triage principles, ethical principles, and communication remains the key. Thank you.
Thank you, sir, for such an erudite talk. Now I request Dr. Vaibhav Bhargav to introduce our last speaker for this thematic session.
supply chains for PPE, ICU devices, consumables, and pharmaceuticals. ICU triad principles, ethical principles, and communication remains the key. Thank you.
Good afternoon, everyone. So we have our next speaker.
Thank you,
Dr.
sir, for such an erudite talk. Now I request Dr. Weber Bhargav to introduce our last speaker for this thematic session.
Supply chains for PPE, ICU devices, consumables, and pharmaceuticals. ICU triad principles, ethical principles, and communication remains the key. Thank you.
Good afternoon, everyone. So we have our next speaker.
Thank you,
Dr.
sir, for such an erudite talk. Now I request Dr. Weber Bhargav.
Yeah, good afternoon, everyone.
Good afternoon, friends. Thank you to the team of World Congress on COVID and critical care. And today I have been given a task of managing a patient with two challenges. That is a severe COVID patient with sepsis. So we all understand sepsis is nothing but an infected patient whose host response has been dysregulated, host immune response has been dysregulated. And this has been mediated by over-amplified local and systemic inflammation by many cells, including the natural killer cell, creating a havoc of both cytokine and chemokine storms, causing both tissue at locally and systemic damage. We have gone through the sepsis causing a lot of pathways activation, including leukocyte activation causing chemokines and cytokines, complement production and that's effect, coagulation cascade effects, and many necrotic cell death related effects. So we have seen the pathogen related damage and then the host cell and host immune dysregulated related damages. COVID is not a separate entity. COVID was also a viral infection which caused immune dysregulation in the host cell. Many asymptomatic patients has very mild kind of infection, and few symptomatic patients also had not much of immune dysregulation, but the severe category of patient who had a severe immune host cell dysregulation causing a wide range of cytokine chemokine storm, leading to multiple organ dysfunction. So this fits into the definition of sepsis 3. So COVID-19 is nothing but a kind of a viral sepsis, which had a lot of unpredictable course and had a add-on higher incidences of thromboinflammation leading to thrombosis and micro and macrovascular coagulation and multiple organ dysfunctions. COVID has not just caused a infection, but also it hit the immunity. It caused a dysregulated B cell response by hyperactive macrophages, monocytes, and neutrophil, and this caused a hyperactive innate immunity. And in the same time, it actually destroyed many of the T cell related immunity, causing a severe lymphopenia, where the CD T cells and natural killer cells immunity has been dropped down. So this lead to a massive elevation of inflammatory biomarkers in a response to increase innate immunity by different kind of neutrophils, monocytes, and the macrophages. In the same way, the function of T cell deficiencies causes lymphopenia and exhaustion of circulating T cells. And these two kind of phenomena finally led into a severe COVID-19 viral sepsis. And it can be again redefined like a sepsis, like a life-threatening organ dysfunction caused by a dysregulated host response to a viral infection called COVID. And coexisting hyperinflammation, immune suppression, unable to actually contain the viral clearance and often leading into fatal endothelial damage, which at the end can lead into a DIC-like coagulopathy in many of these patients. So if you look at the COVID management, one was a immunosuppressive agents which were used in the form of steroids, IL-6 inhibitor, TNF-alpha inhibitor, IL-1 inhibitors, anti-complements, And there were some T cell activity treatments which were given, like a thymosin alpha and all. So these are the kind of phenomena which we saw in COVID. In COVID also, if you look at the severe COVID disease, that is a stage 3, where there is a severe respiratory inflammation cytokine release, where you have seen a high of interleukins 1, 6, TNF alpha, granulocyte colony stimulating factors, interferon gammas, and complements. And this kind of a severe respiratory cytokine phenomenon, which is considered as a hyperinflammatory phase, or some of them also termed this as a cytokine storm, was nothing but a dysregulated immune response, which created a havoc and probably created a lot of tissue damage, that leading to organ dysfunction. So this is again a pictorial diagram how this cytokine storm or the cytokine rise has caused a different organ dysfunction. From the commonest one is the respiratory system, to GI, to central nervous system, to cardiovascular system, to hepatobiliary system, to renal, to the microcirculation, to the ophthalmic. And these are the pictorial picture presentation of different cytokines, from interleukins to tumor necrosis factor, interferon alpha and gamma, and arise from different macrophages, dendritic cells, T cells, and fibroblast and endothelium, causing a different kind of clinical features and clinical phenomenon, from fever to a DIC, to a liver dysfunction, to acute kidney injury, to a rise in acute phase protein. This is again a pictorial presentation of how this hyperinflammatory phase in sick, severe COVID patients, which starts somewhere in the later part of the first week and ends somewhere in the later part of the second week, is considered to be a hyperinflammatory phase, where most of the immunosuppressive drugs like corticosteroids, tocilizumab, purification systems has been used. And then there is a immune paralysis or immune depletion, where you see the immune paralysis can happen in them. So we understand now that COVID was a kind of viral sepsis, which also termed as a cytokine storm, when it was a severe cytokine release. And this also caused a organ dysfunction. Although undoubtedly the direct viral toxicity was also a phenomenon, a dysregulated host response was also responsible for most of its septic phenomenon. Severe COVID-19 meets the sepsis 3 criteria, so probably we can call it a viral sepsis. But the second part of this is the co-infections with viruses, bacteria, and fungus. And some of the other phenomena which happened in COVID is secondary infections, which happened after these patients had immune paralysis, or these patients received some form of immunomodulators or steroids in the second half, when they received any form of invasive lines, and that lead to a secondary sepsis, and that has caused a more challenge. And whenever these COVID-19 patients had an add-on secondary infection or a co-infection, the mortality was very high. So the incidence of hospital-acquired infections were varied in different studies. And this is again another pictorial representation where it shows that COVID had a lot of co-infected viral infections, even though the data across the globe was not very clear. But there were reports of influenza co-infection and some of the respiratory syncytial virus, parainfluenza virus, other entero and rhinoviral co-infection. And this also caused a phenomenon. Coming to the more common bacterial co-infection, even though this analysis shows around 3.5% of hospitalized patients had co-infection, and around 40.3% had a secondary bacterial infection, and they say that almost 71.8%, that is almost close to 72% of patients received antimicrobials. This is a study from India. This experience says the mortality in patients who had a secondary infection was close to 57%. And most of them were caused by gram-negative bacteria, and majority of them were Klebsiella and Acinetobacter. The interesting part is, if you look at 92.6% of Acinetobacter and 72.8% of Klebsiellas were carbapenem resistant. And that is the reason why you can see there is a 57% of death. Every probably alternative patient who had a secondary infection in a COVID severe pneumonia had died. So what we have seen, or the data across the globe, is patients who didn't had any invasive device had almost a similar kind of infection rates of the hospitalized patient what we have seen in non-COVID times. But those COVID patients who received an invasive line in the form of either a central line or a vascular sheath in the artery or a tube in chest, or those who require invasive mechanical ventilation, had landed up in more amount of either bacterial or fungal or atypical organisms. A patient developing, how do actually we picked up this? See, most of the initial first week and the second week, we considered the co-infection rate were extremely or very rare, and we have not seen many streptococcus pneumonia or a staphylococcal infection, what we have seen with influenza in COVID era, and that's what the information across the globe. But in the later half of the second week, the secondary infection and sepsis were a predominant one. So how do we actually differentiate? So most of these rapid progression in first and second week are more correlated and linked with the COVID infection, whereas after the second week, once a patient gets stabilized and improving on oxygenation, but a new onset of alveolar opacities, new onset of rapidly worsening hypoxemia, fever, leukocytosis, or a new color change, sputum or ET secretions should give you a suspicion. Or a patient who was stabilized but had new onset of hypertension or new onset of any organ dysfunction should also give you a suspicion of a hospital-acquired sepsis. This is the data where we had from those 10 hospitals of ICMR which were published in this year's early part, where again the gram-negative were predominant, followed by gram-positive and fungal. And predominant organisms were Klebsiella, Pseudomonas and Acinetobacter and E. coli, followed by Candida and Aspergillosis. So again, how do I manage? We all understand whenever we talk about a COVID, it is more related to the respiratory system and respiratory failure, which we obviously manage with our oxygen therapy or supportive therapy with some form or the other, like HFNC to NIV to invasive ventilation to prone to ECMO. But when it comes to a viral sepsis, again, the same phenomenon, when you start having a viral sepsis with organ dysfunction, the same kind of surviving sepsis guideline, except probably obtaining a blood culture or giving an antimicrobial, the rest all, like probably monitoring a lactate to see the perfusion, giving a volume challenge, and applying a vasopressors when your blood pressures are less than 65 map to maintain a map of more than 65 remains to be a regular standard. And again, the earlier sepsis guidelines remain same for the sepsis which we see in the viral or a secondary bacterial sepsis in these patients, where crystalloids are selected choice of fluids in them and colloids are mostly avoided. Those are starch and even dextran and gelatin, the preferred colloid in only selected group when overzealous crystalloids are already been given. Maybe that is the only indication where the natural colloid, that is albumin, is considered, and norepinephrine was the choice of vasopressors, followed by epinephrine and vasopressin if they are not been adequately managed. And again, enteral feeding, insulin therapy, and lung protective ventilation all remain to be the same standard. So these are the sepsis surviving campaign guidelines for managing a severe COVID patient, including the hemodynamic. The same kind of guidelines use noradrenaline as a choice, followed by vasopressin and adrenaline, and they recommend against using a dopamine. They recommend against using a hydroxyethyl starch. They recommend using a dynamic parameters of skin temperature, capillary refill, and serum lactate measurement over a static parameters in assessing the fluid responsiveness. They recommend a conservative fluid strategy over a liberal fluid strategy in COVID patients with SOC, and they recommend crystalloids over colloid, buffered solution, buffered crystalloids over the saline crystalloids. And they suggest against dextran, they use albumin in selected group, and the vasopressin was used as a second line. The target map was around 65 in them. If the patient had a cardiac dysfunction, which we have seen in some of our COVID patients, and had a persistent hypoperfusion instead of fluid and norepinephrine, they suggested a dobutamine over the increasing of noradrenaline in them. So with this, we do understand the COVID can be a viral sepsis, or the COVID can also add on a new challenge with a secondary bacterial or a fungal sepsis when these patients are sick and are in prolonged stay in ICU with invasive devices. So severe COVID itself can be a viral sepsis with immune dysregulation and thromboinflammation, and single organ may be infected or sometimes multiple organs may be affected, which fits into the definition of sepsis 3, which says a patient who get insulted by infectious agent and had a dysregulated immune response causing organ dysfunction. So that itself fits into the viral sepsis. And the peculiarity of a COVID phenomenon was most of the times it was unpredictable and varied in presentation when it comes to severe COVID disease, and it was a challenge to address many of these concerns. Co-infections like secondary infection causing secondary sepsis in patient with invasive lines like invasive mechanical ventilation, CVC line, arterial line, invasive devices like ICD were more common and caused high mortality. High dose steroids, immunomodulators, underlying comorbidities added a risk to the secondary sepsis. Prevention of the secondary sepsis was the key with standard universal infection control practices, because what we understood is any secondary infection in this severe COVID patient increases the mortality up to 60%. So early identification and also appropriate management and source control in this secondary sepsis may be the key to improve the survival. Thank you.
Thank you, sir, for this enlightening talk. With this, we end our thematic session 1. Now, to begin with the thematic session 2, I request Dr. Utkarsh to take over.
Good afternoon, everyone. Carrying it forward, we'll begin with the thematic session 2. The session would be chaired by Dr. Rajiv Prishak, pediatrician, Pushpanjali Hospital and Research Center, Agra. Dr. Rajiv Lochan Tiwari, Director Fortis Escorts Hospital, Jaipur. Dr. Reshu Gupta, HOD Critical Care Medicine, Health City Hospital, Guwahati. And Dr. Pramod Sood, Associate Professor and Senior Intensivist, DMC Medical College, Ludhiana. Now I would request Dr. Rajiv Prishak to introduce our first speaker.
Dr. Rishu Gupta, ma'am, can you please introduce the speaker?
So our first speaker for the thematic session 2 is Dr. Saud Anwar. He is the chair of the Department of Internal Medicine of Eastern City Health Network, currently serving as mayor in South Windsor City. He is a consultant in British Department of Communities and Local Government, recipient of director, and he have multiple awards in his bag. So I welcome Dr. Saud Anwar. Kindly take over the session.
Hello, everyone. I'm Dr. Saud Anwar. I'm truly honored to be here. First, I wanted to thank the organizers and all the volunteers who have been working for so long to make sure that we put this amazing conference and conversation together. So I am honored to be a small part of this. I am going to be speaking about COVID-19 and public policy with respect to focusing on, do we keep the people alive or do we keep them happy? And I think that's something that policymakers as well as the physicians and scientists have in some respects been at odds with. Let me go deeper into this further. What happens is, first, why am I speaking about this? Well, I'm a pulmonary critical care physician. I'm the chairman of Department of Medicine for the Eastern Connecticut Health Network in the beautiful state of Connecticut. I know the speakers at this conference and the attendees are from literally all over the planet. But I'm going to share my perspective and my background, as I am a practicing physician and intensive care unit doctor in Connecticut. I also wear a hat of serving as an elected official, as a senator in the state of Connecticut in the state. I represent the 3rd Senate District for 4 towns of East Hartford, South Windsor, Ellington, and East Windsor. So as a policymaker who found himself in the midst of a pandemic, and the pandemic very much related to pulmonary and critical care, I feel that I saw things in different parts of the world, but also within the United States, that I think gives me some understanding of the challenges that we have. Now, I do wear 2 hats, so I can, and I also interact with a number of people who are executives managing the decisions, and I've served as a mayor of a town for 2 terms. Here's what happens for the legislators and also people in the executive branch of the government. We are there to serve people. We also are looking at how do we make the community members happy. And what can we do to make sure that we address their immediate needs? The challenge that we have is in this particular disaster, we had a number of people who were very much interested to look at the pandemic in their own way. For example, individuals did not want to wear masks. There have been individuals who do not want to follow social distancing, who do not want to close their businesses when in the initial phase of the disaster. So the policymakers were at a very difficult position in some cases, where they were trying to listen to the people, and at times they're listening to the people who are the loudest. And this resulted in them making choices which may not have been the best choices. So again, the policymakers are looking at how do they keep the people happy. They sometimes are listening to the ones who are the loudest, and that combination is something that can be not healthy when you're managing a disaster. On the other hand, the physicians as well as the scientists, we are looking at the data. We are also looking at what can be done to try and understand the causation, what are the preventive strategies, and then we are also assessing our hypotheses and making sure those hypotheses get tested. And so we have an ongoing way of making sure that our initial prevention strategies, early identification strategies, and management strategies are appropriate, and this continues to evolve with time. So this is how a scientist would look at some of the challenges. Ideally, they should be working in sync with each other, but when you have a disaster which is going to shut down a community, shut down a town or a state or a country, then there are differing opinions, and that is what I think has been part of the challenge. So I'm going to start off by talking about one case scenario, and I will take the case scenario of United States. That's my home, and I will share with you some of the things that could have been done better. But I'm going to illustrate without taking a position, but at least share some of the specific data and dates of what had happened. This is with respect to the beginning of the pandemic, where we had recognized that the disease had been spreading from across Asia to Europe and was on its way to United States. If you recall, our former President Trump in United States was involved in the initial phases, where on January 8th, the CDC had warned that it's a matter of time that this is going to be a pandemic that's going to impact us. At that time, the former president was very busy with his campaigns, and he had 2 rallies right around the same time and had golf outings at the same time. On the 20th of January, the first case was seen in the United States. This is in 2020 in the Washington state. And at that time, within the fact that the disease had landed into the United States, one of the response was from the president that all is under control. There's nothing to worry about. And then he at that time was busy with 6 or so other rallies and about 2 more golf outings. But on February 25th, the CDC and the administration had seen more cases. And at that time, what was said by the president was the administration is doing a great job and the cases will be 0 in a couple of days. Now, here the disease had already spread and the message was that it will be over in a couple of days, and it's like a flu, and the flu is usually over very fast. And this was around February 26th when this was said, and on February 27th, one day, it will take a miracle and it will disappear, is what the president had said. So again, disease spreading. While this is spreading, the messaging coming was that it's going to just vanish in a miraculous manner. There was another political rally on the 28th, and at that rally, the speech from the president, who's the former president, was that this disease is a hoax. It is not even real. So I'm trying to illustrate the messaging where there is an interest to make people happy or also not be concerned, but that is contrary to the ground reality, what the scientists had been saying. And on March 4th, it was mentioned that thousands will go back to work and things will get better from the president, and he actually went out for golf outings on the 7th and 8th of March. And 9th of March, he mentioned that we have been blindsided. The entire world has been blindsided, actually. That was the perspective. And on March 13th, there was a state of emergency that was actually called in. So in the messaging, it was mentioned that it is going to miraculously go away. This is not a real disease. This is a hoax. And then there was conversation about use of a medication, hydroxychloroquine. And in the beginning, even the CDC was talking about that this is not an airborne illness and you do not need any specific N95 masks. You just need a simple mask. And at that time, the PPE stockpile was not shared with many of the states, and the stockpile, and there was ventilators that were in a stockpile that were shared at a very later time with some of the states. So this was a clear divide where the people from the scientific perspective were at a different frequency than an elected official. We saw similar patterns in different parts of the country, and then people listening in different parts of the country right now can look at their own homeland and the places where they have been practicing to see how things went right or wrong in this situation. And I would just add one more thing is that as you look at when things went right and wrong, take that leadership even to the local communities, into various mayors, various governors, how they had reacted and in how they were communicating and who was the source of their information at that time. So I think those things are something that illustrate this example. Let's talk a little bit about social media. And within the social media, while there are multiple different ways of looking at social media, I'm just going to focus on 2 main areas, the Facebook and the Twitter. Within the Facebook, I want you to be aware that right now in October of 2021, we are actually looking at what Facebook did wrong, because many of these anti-vax groups as well as anti-mask groups were organizing within Facebook, and also knowingly wrongful data, wrongful information was being spread, and this was allowed by Facebook, where it was reaching a very concerning level. The algorithmic access that was being provided within these groups added to increasing these groups in numbers and increasing the organization capacity of these groups in numbers. At the cost of the Facebook was getting more marketing out of this whole effort, but there was a disaster that was looming. And I think this is a part of the challenge. On the Twitter side, there were bots that were being used, which were to divide the communities, different parts of the world, to have arguments and differences of opinion on this. And this increases truly disagreements and caused the communities to truly be more and more divided. This was primarily a big challenge that we had, and it continues to be an issue. And then Twitter has probably not been able to address this to the level that they need to as well. So again, I know people have a right to be able to say, as in the United States and in most other parts of the world, but you also have a responsibility with that right. In other words, we use this example that people cannot yell fire in a full movie theater, and that is a challenge. Now, in this particular case, there was a fire, there was not a movie theater, but the entire world, and these groups or individuals who were actually yelling fire were coordinated with each other. They were organizing with each other, and they were sending people to different exits or to places where there were no exits and causing a stampede. And I'm using figuratively the challenges that we were having, because the misinformation that actually was organized and was knowingly spread caused a governance failure where individuals who were trying to get this messaging, so the messaging got messed up. The ability of these groups to continue to become loud and organized because of the social media added stress on the policymakers who made bad choices in those difficult times. So when somebody, and I'm going to make a statement, when this is done by a group, this is done by an organization or done by a country knowingly to another part of the world, and it results in misery and death, this is nothing short of weaponized communication, and this is nothing short of essentially an act of war at times when somebody is providing information and trying to give negative, wrongful information in the midst of a disaster leading to more deaths. That's very, very dangerous, and we saw this pattern as well. So what do we need to do, and how do we address this? What is the way to approach some of these difficult challenges at this time? Well, the important thing is that in the disaster goes through multiple phases. One of the phases of the disaster, you have to have a prevention strategy. The prevention strategy is to actually build resiliency and organize systems where the individuals with the right skill sets are available to look at the data, look at the information, and identify ways to do this. So know the disaster, have a group of people who can identify and manage the disease, and have subject experts that are there, and create scenario with the appropriate contingency plans and communicate that's also part of the preparedness. So you actually have a prevention where you identify how you can prevent the illness and the disaster to happen, and then you move on to have a preparedness strategy. When we are talking about preparedness, we look at 3 S's, which is the space. We need to provide space when the disease is going to spread. We need to have staff to be able to manage this, and we also need to have supplies, whether it's going to be medications, antivirals, ventilators, oxygen supplies, and so on and so forth. Those are the things that are part of the preparation strategy. So again, knowing what is going to be the risk to the community, having a preparation strategy, and then implementing the response in a manner to be able to save as many lives as is possible. Again, that is going to be part of it to get potential surge capacity within a system, within a community, whether it's a town, whether it's a state, whether it's a country. We have to have some of those implementation strategies, and then move towards recovery, whether the recovery is going to be to try and take care of the individuals who have lost their jobs or physical capacity, but also the financial losses that were being in place in that situation. So those are part of the challenges there, and then we have to learn from every disaster. No disaster should go by without people becoming smarter and more efficient and effective. And whether it's happening in one part of the world or the other, we should be able to learn. And I think this was another missed opportunity where we knew what was happening in China, we knew what was happening in parts of Asia, and we knew what was happening in parts of Europe when Italy was going through its challenges. And then having to reinvent that wheel every single time in every single country where the disease was spreading was a missed opportunity, because the virus was not changing. The virus spread rates were not changing. So we could have done better at that time. Now, here's the other reality. Look, the unfortunate reality is that In our current world, there will be ongoing challenges. The challenges would include the infectious disease related pandemics or epidemics in communities. We have to recognize that climate change is a real issue, which is progressively going to cause more challenges in the communities with disasters. And the third thing that we have to look at is that there's going to be a risk of man-made disasters in our planet right now. Unfortunately, with some of the challenges that we have within communities and people and countries, that is going to be an added problem. And then, of course, the natural disasters remain a challenge. So between all of these natural disasters, human-made disasters, and moving towards infectious diseases that are brewing and changing, all of those are going to require us to be better at what we do. We need a stronger public health structure, and we need to have policymakers who are in sync with this, because what has happened is that, as I started off by saying, that the policymakers are interested to keep people happy at the cost of not keeping people alive, and the scientists and everyone is interested to keep the people alive and at times not making them happy. And finding that balance, but cost of saving lives and then making sure that lives that are going to be lost are saved, because that's irreversible. And people can be unhappy, but they will become happy when they realize what was done was right to save as many lives as that could be possible. So with that prism, with that mindset, going forward and recognizing that the needs are going to be there, we have to move forward in this direction to have a stronger public health system, have a surveillance system from infectious disease point of view, and have a robust first responder system across the different parts of the world and in your community that you're responsible for. We need workforce development around this area. We need communication systems around this area. We also need to have protection from misinformation, because we know what the misinformation can be create, and having a communication strategy which is very clear and there is a well-organized system there, and then recognizing that you need to, or people who are in positions of responsibility need to surround themselves with people who feel comfortable disagreeing with that person in a closed room, so that the best decisions come out, the best decisions that are made that are going to actually identify ways of saving people. And anyone who feels that it is okay to let people die so you can make a small loud group of people happy, I would say my bias right now, you should not be serving in any responsible position, because this is something that actually is the sad part and the sad part of this entire pandemic. Decisions should be made in collaboration with professionals based on professional data, and also continue to have education and update that, because as we learn about this disaster, infections and changes in pattern, we should be in a better place to be able to address those as well. Again, training people is in planning to serve as legislators is going to be critical, and people in the executive branch of the government need to recognize that they will need a better understanding of disaster management. They are at times the frontline workers, and sometimes people may look at it as photo ops or other opportunities, but in reality, it is real lives, real people who are suffering, whose life we have a responsibility to save. So I can speak on this topic for a much longer time, but I wanted to have this in front of you and then see if we can have further more conversations, and I would love to be able to answer any questions you may have. Again, congratulations to all the organizers for doing an amazing job to get thousands of people be a part of this conference, and hundreds and thousands of speakers from across the world with expertise in their areas speaking on this topic. And again, I'm honored to be part of this. Thank you so much.
Thank you, sir, for the wonderful session. Now I would request Dr. Pramod Sood to introduce our next speaker.
It is a privilege to go about introducing our next speaker. He is none other than the Munish Nakra. He is the head critical care department at Venkateshwar Hospital, New Delhi. He is instructor of ACLS, BLS, and ATLS and FCCS courses. He is a renowned speaker and has presented various papers at the National Critical Care Conference. He is a number of research publications in international and national journals, and he has been a pioneer in bringing the critical care services in the Arm Hospital, New Delhi. and he's done his diploma, MD anesthesia from AFMC Pune, after which he was part of Kaman Hospital, New Delhi. So, but presently he's working as a head critical care department at Venkateshwar Hospital, New Delhi. I invite Dr. Munish Nakra, and he would be speaking on all the COVID vaccines. They are not the same. Over to Dr. Munish Nakra, please. Can we have the slides recorded lecture of Dr. Nakra, please?
Technical team, can we please have the recording?
The voice is not.
So what's in a vaccine? It's got an active ingredient, which is a very small amount of a harmless form of bacteria or virus that you are immunizing against. It has adjuvants, which create a stronger immune response to the vaccine. They pose no significant risk to health in very small quantities which are used. They would, of course, have preservatives and stabilizers, which serve the purpose that the name specifies. And of course, water makes up as the balance of the ingredient. They would have residual traces of substances that have been used during the whole vaccine manufacture process, but no issues with that. Now, what really happens in a viral infection is there is an immune response. There are two types of immunity. One is an innate immunity, which is the general immediate response to any infection. But what we are talking about is the adaptive immunity, which is the specific response to an infection, and it involves the cellular response, that the T cells, and the antibody response, that the B cells. Now, this innate immunity or response, the innate immunity is immediate, whereas the cellular and antibody response usually starts in about 6 to 8 days' time. Now, this is the one, the adaptive immunity is the one that any kind of vaccination process targets. Now, in an immunized person, the response happens in the form of adaptive immune cells, which are B cells and T cells. They encounter the same virus. When the same virus is encountered again, they respond rapidly, and an immune system can effectively clear the infection before it can cause a disease. The vaccines use this immune memory to protect us from infection. Immune memory can result from a prior infection or from effective vaccination. Here we are speaking of effective vaccination. So what really happens when the first jab of COVID-19 vaccine is given? After injection, the vaccine contents enter our cells at the injection site with the genetic material for the spike protein. Now, spike protein is the part of the virus SARS-CoV-2 that allows it to enter our cells. The spike protein is produced by our cells and presented on the surfaces. This trains the immune response by activating the helper T cells, killer T cells, and the B cells. The helper T cells that detect the spike protein and alert other immune cells. The killer T cells seek out the spike protein, and the B cells that create antibodies to specifically recognize the spike protein. Once the T and B cells develop immune memory of the spike protein, they are quick to respond to the next time that any kind of infection is encountered. Antibodies remain in the body for some time, ready to bind to the spike protein and block the virus from infecting new cells. B cells can produce more antibodies if needed in the future. Now, once a second vaccine dose is administered weeks later, this trains the immune system further, strengthens the response, and creates an immune memory to the virus. The immune system is now ready to launch a quick and effective response against SARS-CoV-2 if it encounters the virus in future, preventing infection and serious illness. Now, up till now, this is how the vaccines are not different. Now, this slide onwards is how they're going to be different. So, all vaccines use immunogens. An immunogen is a specific type of antigen that is able to elicit an immune response. choice of immunogen of vaccine impacts what type of vaccine response is induced, as well as safety, development time, production time, cost, and access to vaccines. Immunogens used in current COVID-19 vaccines or COVID-19 vaccines in development generally are the inactivated virus, the viral subunit, which could be maybe protein or anything else, viral vector, which is the inactivated one, and of course the RNA vaccines or maybe even the DNA vaccines. Inactivated virus as the immunogen essentially uses inactivated or dead virus. The viral subunit as an immunogen uses a protein derived from a pathogen. The viral vector as an immunogen in this uses a viral pathogen which is expressed on a safe virus that doesn't cause disease. And the nucleic acid mRNA coding, the nucleic acid uses mRNA coding for a viral protein or maybe even a DNA. Just to take it one at a time. Inactivated vaccines use or contain killed SARS-CoV-2 virus. The killed virus is recognized by the immune system to trigger a response without causing an illness. This response builds immune memory so your body can fight off SARS-CoV-2 in the future. This is what our integral and indigenous Bharat Biotech Covaxin is using, of course, apart from others like Sinovac and Sinopharm. The attenuated vaccines use weakened SARS-CoV-2 virus. The weakened virus is recognized by the immune system to trigger a response without causing illness. This response again builds immune memory so your body can fight off SARS-CoV-2 in the future. There are trials for numerous vaccines. One of them is, of course, Codagenix. The viral subunit uses antigen of the virus without any genetic material, usually with an adjuvant to give a better immune response. Usually made using recombinant expression system made in a cell without using the virus. With the help of antigen-presenting cells, the antigens are recognized by the T helper cells as with a real viral infection. Subunit vaccines generally induce mainly antibody-mediated immunity. Adjuvant can enhance the antibody response and also cell-mediated immunity. The vaccine on which the major research is being done are the protein vaccines as the part of the viral subunit. They contain proteins from SARS-CoV-2 virus, which are recognized by the immune system to trigger a response, can be whole proteins, protein fragments, or many protein particles packed into nanoparticles. This response builds immune memory so your body can fight off SARS-CoV-2 in the future. The trials are on for Novavax, Sanofi GSK, and others. Then we come down to the viral vector vaccines. Now, this uses an unrelated, harmless virus modified to deliver SARS-CoV-2 genetic material. This delivery virus is known as a viral vector. Our cells uses the genetic material to make a specific SARS-CoV-2 protein, which is recognized by the immune system to trigger a response. This response builds immune memory so your body can fight off SARS-CoV-2 in the future. Here, of course, the more popular, the AstraZeneca Oxford and our very own Serum Institute, the Covishield, Johnson & Johnson Janssen, they all use these viral vector, are all viral vector vaccines. Then we come to the genetic vaccines, which are the nucleic acid vaccines, which could either be a DNA or RNA. These contain a segment of SARS-CoV-2 virus genetic material that codes for a specific protein, can be DNA or RNA. Like I said, our cells uses the genetic material to make the SARS-CoV-2 protein, which is recognized by the immune system to trigger a response. This response builds the immune memory so your body can fight back SARS-CoV-2 in the future. This, of course, very prevalent, very popular, internationally used. Pfizer, BioNTech, and Moderna are the vaccines which use the RNA. For DNA, the Inovio pharmaceuticals, and of course the Zydus Catalog are the ones which are in the fray. A very quick snapshot of the three international used vaccines: Pfizer, BioNTech, Moderna, and Janssen. The first two are mRNA. The other one is, of course, a replication incompetent adenovirus type 26 vector. The first two have got a couple of doses, and of course, going on to taking even booster doses. Janssen, of course, advocates only one. Now, this is like an important kind of a slide, which gives you a snapshot of everything that we have just spoken of up to now. So if we see on the left, The inactivated or the attenuated vaccine, the uses a form of the virus that has been inactivated or weakened so it doesn't cause a disease, but still generates an immune response. The virus vector, which is a non-replicating, which is commonly used, uses a virus that has been genetically engineered so it can't cause disease, but produces coronavirus proteins to safely generate an immune response. The protein subunit uses harmless fragments of proteins that mimic the COVID-19 virus to safely generate an immune response. The DNA vaccines, which synthetic DNA fragment, the plasmid that encode a COVID-19 antigen, and of course the RNA that typically the RNA segment of the viral genome that codes for the virus spike protein or other antigenic region is prepared in a suspension of lipid nanoparticles. Now the first four would also contain adjuvants. The RNA would contain lipid nanoparticles, NLPs, present in the RNA vaccine only. So, but why are they there? They're there because they would want to be enhancing the immune response and reduce the dose of antigen needed. Example, by stimulating the body to produce more antibodies or a longer lasting immune response. They encapsulate and protect the RNA, that is the lipid nanoparticles I'm talking about. They encapsulate and protect the RNA and help it enter the body cells where the RNA can start producing the desired protein that will produce the antigenic response. As per the latest WHO data, as of 1st October 2021, there are about 123 COVID-19 candidate vaccines in the clinical development, of which 26 are in phase 3 trials and 8 are in phase 4. There are another 194 candidate vaccines in the preclinical development. Around 77% of all the candidate vaccines are being delivered through the intramuscular route. About 35% are using protein subunit vaccines. And about 62% are recommending 2 doses of the vaccines to be used. Now, most of the vaccines are designed on a 2-dose schedule. The first dose is the priming dose. It primes the immunological memory, and the second dose solidifies it by using a booster kind of a dose. Now, after the first dose, the immune system needs time to regenerate a response and to create memory cells that will recognize the pathogen if it is encountered again. A larger time interval between the first and the second dose, it's been studied, may induce a stronger immune response compared to a shorter time interval. Now, are these COVID-19 vaccines, which have been there or in the future, can they handle the SARS-CoV-2 variant? Now, studies are on for exploring the development of COVID-19 vaccines that make it difficult for the virus variants to evade immunity. For example, there is study on multivalent vaccines that include both new, that is derived from the variants, and the older forms of the spike protein in a single dose. Vaccines that target multiple sites on several viral proteins, in contrast to vaccines that target only the SARS-CoV-2 spike protein, are also being studied. To end, give you a snapshot of most of the vaccines which are around. These are either in advanced phases of trials, or they are already prevalent in use. Little dated slide, because numbers keep on getting on even as we speak. The RNA-based are the Pfizer, BioNTech, and the Moderna. The viral vectors are the AstraZeneca and the Janssen. And the inactivated viruses are the Sinovac, the Sinopharma, and the Biotech. The protein subunits under study are the Novavax, and of course the DNA-based vaccine are the Zydus Cadila. I've finished. I would gladly take on any questions which anybody would have.
Thank you, sir. It was a wonderful session. Now I would request our next chairperson, Dr. Rajiv Lochan Tiwari, to introduce our next speaker for the session, that is Dr. Narendra Malhotra.
Yeah, show me the slide. Thank you very much. Good afternoon, everyone. Dr. Narendra Malhotra is a well-known figure. He is Managing Director, Rainbow Hospital, Agra. His specialties are FOGS, Ethicon Traveling Research Fellowship Award 1986, he got it. Indumati Javeri Award for the Best Research Paper presented in National FOGSI Conference in 1987 in Ahmedabad, he got it. Jagdeshwari Mishra Prize of the Best Poster Presentation in 1991, 92, 93, 95 5 times. His Asia Ocean Young Gynecologist Award was also given to him at Manila, Philippines in 1993. He's just one of the best 17 scientific research posters presented at the World Conference of FIUGO Canada 1994. I welcome you, Dr. Narendra Malhotra, to please take up the topic and enrich your knowledge to everyone. Thank you very much.
Technical team, can we have the recording, please?
Namaskar, greetings. I'm thankful to the World Congress of COVID and Critical Care for inviting me here to express some of my views on management of labor and delivery in women with COVID-19 infection, our experiences in our center in Agra. The pregnancy offers a lot of challenges. We know that. Pregnancy is more susceptible because of physiology, immunosuppression, comorbidities. About 10% are symptomatic and 4% will be asymptomatic, as per the study says. A pregnant patient had a more risk of abortions, preterm deliveries, unexplained IUDs at 20 weeks, and unexplained full-term IUDs. So it's very important for the healthcare professional to know about it, and very important for the patients to inform the healthcare professional. The disease in pregnancy can be classified in 4 ways: mild to moderate, severe, critically ill, and immunocompromised. And the immunocompromised are very important for us, especially for us, because we are dealing in IVF ART, and these are elderly patients, and there they may present atypical symptoms. So what we need is, we need our facility to be prepared. What we did in Agra, we'll tell you. What we did for infection control, how we triaged our patient in antenatal, how we triaged our patient in delivery, and what we did for cord clamping and postpartum care. So preparedness as per WHO is very, very essential. And we followed the ICMR and WHO guidelines so that the infection does not spread from woman to woman, or healthcare professional to woman, or woman to healthcare professional. And these guidelines were clearly given by ICMR to follow a standard operating procedure for antenatal. See, this is a Western clinic up there, and this is our clinic down. So similar, modified, but our people were wearing PPE, giving sanitizer cleanage, and they were screened before and temperature screening. While here, you see they were a little bit casual about wearing masks. So that is what every woman has a right for a child positive childbirth and respectful maternity care. So we need to be prepared for the advice given to this. And this preparedness is need to have a proper standard operating procedure, the infrastructure to be ready. Small hospitals did face the problem of infrastructure, PPE, which was initially very difficult, but then got easier, personnel to be trained, mock drills and mock drills and mock drills, and infection control procedures. We followed the standard operating procedures given by the All India Institute and modified it according to our small and big hospital need. So our maternity room was segregated in a different building for COVID and for COVID suspect. And they were put curtained, and they would deliver, and the neonatal resuscitation tray was as per the standard operating guidelines. The PPE, according to the need, different type of PPEs and protective gear was. Initially, my team was very, very scared of this infection, and before going to the OT, see what we are doing. So we did a lot of mock drills, and then we defined to this team on which PPE is good for which worker. So the Safai Karamchari, the nurse, everyone different. So infection control, luckily our labor room had all the exhaust in the 4 areas. So we had clean circulation of airs. But after every case and in the night, a proper fogging was done. So fogging machine was put, and the whole OT area and the labor room area was sterilized very nicely. The triage zone was defined. Fortunately, our hospital had a different block, which was used for COVID, and we called it the D block triage zone. The patient would walk in, screen for temperature, screen for this thing, nasal swab taken, put in the green area. And if there was no temperature, if there was temperature, put in the orange area. till the report comes, and then shifted to the red area. And that red area could be either critical care, which goes to the COVID ICU, or the red area in the labor room area. So the triage has to be very, very important on antenatal clinic examinations, showing, and also in delivery. And the case has to be defined. So we had to know which case is confirmed and which case is probable. In labor, all probable cases were taken as confirmed cases till the RT-PCR report came. And a multidisciplinary team would see them in pre-labor. If they had to go home, they'll be sent home with a proper advice. If they had to stay, they would stay in the orange or the red area, depending on the severity. So nasal, after sending the swab, the obstetric care is not delayed. So if she's in labor or she's in pre-labor, the obstetric care has to continue and respectful maternity care has to be given. If she goes home, the home isolation protocol has to be followed by her, and video conferencing, and to be on our app. We have a pregnancy care app, which is known as iMums, and this iMums app, they can communicate with the doctor anytime they want. So the severity of cases going into labor were assessed by SOFA scoring on moderate, minimum, pneumonia, immunocompromised, critically ill. So systemic SARS positive patient, sequential organ failure assessment tool, and maternal early warning or MUSE score. So these were the things which we did: systolic, diastolic BP, heart rate, respiratory rate, oxygen, oliguria, maternal confusion, and PIH patients. And they were done with a quick sequential organ failure tool. So to segregate them by the severity. And this is how the roadmap for segregation. If they needed only monitoring, in the gray, orange or gray, red area. If they needed ICU admission, go into the ICU. And if they needed emergency cesarean section, transfer to the COVID OT area. So mothers were monitored repeatedly in the antenatal, in the labor, and post-delivery also by temperature, where required imaging, and oxygen saturation and oral hydration. Drugs for fever, for anti-infectives, for infection screening, other screening, and thromboprophylaxis, depending on what they required. And we did try a lot of combination of drugs, which as they were coming and going, they were tried by us. Luckily, vertical transmission was seen in only 2 of our cases out of the 62 which we delivered. And so we were not, though they were segregated into a separate NICU care, but with proper precaution. But 95% of the babies were in good condition. There were placental damages noted by us as thrombosis in the placental vessels. And that is why a lot of deliveries had to occur early, and a lot of people did land up into intrauterine fetal deaths also. Post-delivery or the antenatal care, if they got well, they go home, or post-delivery, they were maintained or for a few days in the hospital, 10 days or 14 days, depending on the negative test. And these were the precautions taken by footwear, by wearing gloves, proper masking, proper hand washing, and after every case, the doctor and the healthcare workers taking a shower and changing into a fresh PP. The neonates were also handled carefully, though the vertical transmission was less, but they were handled with all full care, with full precautions. We took out our own flyers of precautions, which are widely circulated in our mock drills to our patients for hand washing, for our healthcare professionals, nurses, and Safai Karamcharis and all, how to dispose the mask, how to dispose the COVID this thing, what when to wear N95. And this is what I was telling you, the iMums app. Very good pregnancy companion for patients who need pregnancy advice and those who need to talk to someone or to listen to someone. This gives a lot of Garb Sanskar, a lot of Garb music, yoga, meditation, common diseases, common problems in pregnancy, how to take care of them at home. For management, of course, all the ICMR guidelines were strictly followed. Here and there, some drugs were added and some drugs were not added. And to tell you frankly, we did try some herbal medicines and Ayurvedic drugs also, though there is no evidence. And we also could not have enough evidence because of the only 62 cases. So we could not produce a paper out of that. The algorithm has to be followed very, very carefully. And this, we paid clear attention on following the algorithm for management in pregnancy and labor. Labor care was a little extra, and labor care separate areas. So the labor ultrasound machine was separated, labor OT was separated, labor room was separated. The neonatal resuscitation trolley was put into the labor room and into the OT, and proper, you looked how properly the cesarean is being performed by me and my assistant, and how my pediatricians will look after it, and how the baby is being handled by the gynecologist here and by the healthcare professional here. Again, here for labor, all ICMR guidelines on premature labor, preterm labor, when to give steroids, what drugs to give, when to give remdesivir, when to give ZAMs, when to give steroids, all were followed to the book, except for a little bit of oxygen therapy and extra care which we used to give. So no protocols to be altered, and protocols and mode of delivery not to be altered. If they're delivering vaginally, let them deliver. If their condition is deteriorating, cesarean section. But if normal delivery is going to take time and the mother needs more oxygen therapy, then of course deliver them out. And then of course the patient's preference was also kept in mind. Some patient did demand a cesarean section because they were feeling very uncomfortable with the mask and all. Some patient had to be planned induced in pregnancy, and if they were preterm, then after steroid coverage. If they were not preterm, then planned induction into the red zone or the triage orange zone with full precautions again. So timing of the delivery depended on the patient's clinical condition and the fetal condition. If they had to be done, sometimes prematurely also. During the pregnancy and delivery, oxygen saturation to be maintained more than 94, depending on the oxygen to be given to them. And then assessment by SOFA and Muse to which patient goes into the ICU. So SOFA on BP, respiratory rate and altered consciousness, quick sequential organ failure tool, 2 out of 3, they go there. Muse on systolic, diastolic, heart rate, respiratory rate, oxygen saturation, oliguria, maternal confusion, known patient with preeclampsia. This would be the maternal early warning signs. And if there was septic shock, organ failure, immediate cesarean section. So this balance had to be maintained and should be maintained by all of us. We have to learn from each other. And that is why we try to follow from the AIMS, from the ICMR, from the Western guidelines, and did make our own guidelines. Anesthesia, we left it to the anesthetist. If she was fit, they could give a general anesthesia, but then aerosol generation was a lot there and put the whole OT on risk. And epidural and spinal analgesia and anesthesia, no evidence it is contraindicated, so was used also. The surgical procedure with full aseptic precautions and full precautions was done. Lastly, post-delivery, the timing of oxytocin for active management of third stage of labor, or carbetocin, which we have started giving now, or prostaglandin, delayed cord clamping as we do. What changed here was the skin-to-skin contact. Usually when the patient delivers under spinal anesthesia, cesarean, the baby is straight away put on the breast of the patient and she can feel and touch the baby. So the skin-to-skin contact is done immediately in our setup. But here, if the patient was coughing or very seriously ill, this procedure was abandoned and not done. Breastfeeding is safe, as WHO said, with proper precautions. Mask, washing, disinfectant, and if the mother could not feed, then express breast milk in the... We were still worried. In COVID-1 wave, we were very, very worried. COVID-2, we were even more worried. And my whole team, before going into the OT, would always say, oh, doctor, please leave it. Let's not do COVID cases. Then they started seeing the government putting advertisements on management. COVID is not to be scared. Here is what you can do. So these did make life easier for the patient, but I still feel the drugs should not have been advised. We followed this protocol and we made our own protocol by adding a little bit of antioxidants and the others in it. And this is how our patients recovered. This one is recovering. She's on still on a hood, and this one completely recovered, elderly IVF patient who delivered elderly and gone home. All patients, all staff had to maintain on their floor a chart like this and WhatsApp to the doctor concerned or video conference with the doctor concerned every 2 hours. The AIMS guideline is probably the best for managing mild, moderate, severe disease. And the Government of India guidelines of the Ministry of Health, asymptomatic, mild, moderate, severe. Same applies for pregnant patients. And this glance box chart should be put in all labor rooms. All patients where COVID is being monitored, not even pregnancy, non-pregnant also. And healthcare workers should be given mock drills on recognizing these symptoms. And what drugs, we used everything in some patients, this, that, what worked in patients, what did not work. We did lose a lot of patients. We did have a mortality which was higher than a normal mortality. But what all our healthcare workers and all the patients should be know is useful is how COVID progresses. So 14 days, you will be infected very severely, and then the antibodies will come, and then you'll be there. And they should know what they should have in the home. So they should have a pulse oximeter, a thermometer, a respiratory exerciser, sanitizers, emergency oxygen, some antioxidant sprays, a box of surgical masks, pad and pen to note, and plastic gowns, PPEs, and of course, religious material, meditation material, music, prayer books, everything. We would give them everything of this. So ladies and gentlemen, to summarize, same recommendation for non-pregnant patient. The take-home message is pregnant women should follow the same recommendation as non-pregnant. Antenatal care should be more by telecall. We call them once a month, 9 times antenatal care. So here reduce the antenatal care to 4 times or maybe even 3. Ultrasound we would do 5 times. So reduce it to 2 or maybe 3. And when they come, a triage based on symptom severity and assessing them by Muse and SOFA, and then putting them into different categories. So this is how we did, and this is how we followed when the vaccine came, all of them were advised vaccination in bold written letters on all prescriptions. Some people did not agree in that time, but now everyone is agreeing to get vaccination, and vaccine had protected. So when this virus is
Thank you, sir, for sharing your experiences and for such a wonderful lecture. Now I would request our chairperson, Dr. Reshu Gupta, to introduce our next speaker, Dr. Soumya Shankarnath.
Can we have the speaker's slide, please?
Okay, so the last lecture for this session is to be presented by Dr. Soumya Shankarnath. He is the professor of anesthesiology and critical care medicine in Ram Manohar Lohia Institute, Medical Sciences, Lucknow. Over to Dr. Nath, please. Can we have the slide, please?
Respected chairpersons, a very good afternoon. I would like to thank the organizers, particularly Dr. Narendra Gupta, for giving me this opportunity to present in this August platform. Well, I've been asked to talk about antibiotic dose optimization in COVID patients. So before we go to the topic, let's just see what was the trend of antibiotic uses during COVID pandemic. It was found that the bacterial co-infection was only identified in 3.5% of patients, and secondary bacterial infection in COVID patients was to the tune of 14.3% of the patients. So the overall proportion of COVID-19 patients who developed bacterial infection was around 7% only. But surprisingly, the majority of the patients with COVID-19 received antibiotics to the tune of almost 90%. For this, we have to blame the government policies, which suggested that even for the milder variety of infections, COVID infection, we should give antibiotic like azithromycin that was prescribed. So coming to the introduction, deciding the optimal antimicrobial dosing in critically ill patients is challenging, and therefore it is essential to understand the relationship between the pharmacodynamics of the drug and to the extent pharmacokinetics are altered by the illnesses and their medications. There are several factors like obesity, pregnancy, extremes of age, comorbidities, and polypharmacy, and extracorporeal strategies like CRT and ECMO, which influence the PK/PD of patients who have developed COVID as well as sepsis. Before we go to the optimal dosing, we need to understand certain terms. Among them, the first is the bioavailability of the drug. It is defined as the fraction of administered drug that reaches systemic circulation in unchanged form compared with the same dose given intravenously. There are several factors which influence the bioavailability of the antimicrobial agent, like pharmaceutical preparation, physicochemical interactions like with food, with other drugs, patient factors like impaired gut absorption, gut stasis, hypoalbuminemia, rate of fast-pass metabolism, and we should also understand there are certain drugs which are not absorbed at all, like rifaximin, which exerts its local action only. Now, the next important term is the volume of distribution. It is defined as the apparent volume into which a drug disperses. In order to provide the observed plasma concentrations. Factors influencing volume of distribution are the lipid solubility of the drugs, the level or degree of ionization at physiological pH, extent of binding to plasma and tissue proteins, presence of tissue-specific transporters, differences in regional blood flow, and the volume of distribution of any drug is obtained by the ratio of the dose administered by and the plasma concentration of the drug that is achieved. The next important point that comes is the drug-drug interaction. Before that, little bit more about volume of distribution. It is commonly increased by increased total body water, capillary leak syndrome, and fluid resuscitation. Increases the volume of distribution and results in underdosing of antimicrobial agents. Hypoalbuminemia results in increased free drug concentration. Muscle wasting has low volume of distribution, so higher antimicrobial concentration in the blood. Regarding drug-drug interaction, drug interaction refers to the modification of response to antimicrobial agent by another drug, which are administered either simultaneously or in close succession. And its possibility increases in the critically ill patient because there are so many drugs which are being administered at the same time. We know that certain drug-drug interactions are desirable, like sulfamethoxazole and trimethoprim, furosemide and spironolactone. But in several instances, these interactions are not desirable because they render them ineffective, like the enzyme inducers, or toxic because some drug will displace the antimicrobial agent from their binding sites. Now, coming to the specific situations where drug dosing becomes difficult, one is the drug dosing in renal impairment. We know that renal dysfunction affects the hydrophilic antimicrobial agents more, but certain renally excreted metabolites of even moderately lipophilic drugs are also affected. So we know that there are two types of antibiotics as far as their killing efficacy is concerned. One is the time-dependent killing. These drugs, like beta-lactams, cephalosporins, etc., their dose should be reduced. And those which act by concentration-dependent killing, like aminoglycosides, the dosing frequency should be extended. Fortunately, we have the creatine clearance, which, in spite of its several limitations, provides a reasonable guide to alterations in antimicrobial doses. Now, drug dosing in acute kidney injury, regarding the hydrophilic loading dose, the hydrophilic drugs like beta-lactams, cyclosporins, carbapenems, etc., their dose should be increased by 25 to 50%. And regarding the maintenance dose for most antimicrobial agents, they should be maintained at normal or near normal levels. Why? Because we should remember that the preservation of non-renal clearance often is preserved, even in case of AKI. For example, with vancomycin, imipenem, and ceftriaxone. But at the same time, because of the increased volume of distribution, the maintenance dose need not be altered. In CKD, the loading dose is not recommended, but maybe in certain cases of antimicrobial agents which have a very long half-life and where we need to achieve the desired steady state concentration early, a loading dose might be indicated. Regarding the maintenance dose, we should prolong the dosing interval but maintain the same doses. Regarding drug dosing in hepatic impairment, unfortunately, there's no single parameter which is directly related to drug clearance, edge creatine clearance in case of renal dysfunction. Now, the dosing of the drugs in case of hepatic impairment depends upon the level of elimination through the liver. When more than 90% of antimicrobial agents is excreted unchanged in urine, no significant effect on elimination, so drug dosing is not altered. But for those in which limited hepatic elimination occurs, that is less than 20%, Among them, those drugs which have a wide therapeutic range, there's no drug dosing modifications required because there's no risk of unsafe systemic exposure. But those drugs which have got a narrow therapeutic range, we need to reduce the dose, or a longer dosing interval should be used. For extensive, more than 20% hepatic elimination, reduced dose or longer dosing interval is recommended. And those antimicrobial agents which have a very therapeutic range, they should be avoided at all, altogether. Now, there could be certain drugs about whose the extent of hepatic clearance is not known. In those cases, we should consider the compound as extensively metabolized. Now, those patients on renal replacement therapy, among them those who are on intermittent hemodialysis, that a dose of antimicrobial agent should be administered after dialysis. This is called DHD, to ensure that the active drug levels is maintained until the next dosing. A supplemented dose, DSUP, in addition to the dose adjusted to kidney failure, may be considered. Now, this DHD or the hemolysis dose is the sum of the dose DFill plus DSUP, but DSUP is the effort by the difference of the DSTAT and DFill. The DSUP values that are available in the net and on the insert of the drugs that have been derived from low flux non-synthetic membranes, but which were available earlier. But we should remember that these days high flux synthetic dialyzers or extended dialysis regimes like SLADE are often used. So in those cases, the DSUP value should be increased by at least 50%. Now, those patients who are on continuous renal transplant therapy, we should remember that there are changes in the volume of distribution. So more aggressive dosing needed for antimicrobial agents with large therapeutic windows and low levels of toxicity. We should remember that during the course of CRRT, which may last for around 72 hours, the residual renal function may change, and so the dosing strategy should be changed accordingly. And residual renal function should be evaluated daily. And when CRRT is stopped, we should remember that drug dosing should become similar to patients on intermittent hemodialysis that we discussed in our previous slide. This is a recommended antimicrobial dose during CRRT. And there are certain drugs which do not need any dose modification during CRRT. This is important, like drugs are amphotericin, azithromycin, ceftriaxone, clindamycin, doxycycline, linezolid, metronidazole, micafungin, oxacillin, rifampicin, tigecycline, and voriconazole. Now, drug dosing during ECMO. During ECMO, there are two things happening together. One is the volume of distribution is increased, and again, there are several drugs, particularly the lipophilic drugs, which get absorbed on the ECMO membranes, and so their serum concentration is reduced. Renal replacement therapy further complicates drug dosing. So due to higher volume of distribution, certain drugs like aminoglycosides, beta-lactams, and glycopeptides, they need higher doses during the first 24 to 48 hours of therapy. So to conclude, it is challenging to optimize antimicrobial dosing in critically ill patients. There are multiple factors which alter the plasma concentration of antimicrobial agents. And we should understand that the underdosing of antimicrobial agents is rampant in critically ill patients, and particularly those on extracorporeal therapy like renal replacement therapy or ECMO. And we should also remember that the MIC values and the drug doses were all devised when the drug is newly introduced to the market, when its resistance level is very low. But with time, we know that the drug becomes more resistant. So those doses might not be suitable. Again, those doses were suitable for non-serious patients, but critically ill patients, they usually need higher doses than the doses prescribed. Again, while deciding on doses of antimicrobial agents, we should remember that controlling the infection deserves priority over preserving oxygen toxicity. If the infection is not controlled, organ dysfunction will never improve. Thank you. If there are any questions, I am available.
Thank you, sir, for such a good session. Here on, I would hand over the mic to Dr. Ayushi.
I would like for a comment upon by Dr. Nath regarding the use augmented renal clearance, if there is any specific comment on augmented renal clearance, particularly in COVID patients. Hello.
There are no data as such specifically regarding COVID patients, but when they go into sepsis, they are just like any other patient, sir.
Because inflammatory markers, and when we talk about the cytokine storm, at that particular point of time, there is the dosing needs to be modified, particularly when you have augmented clearance. Yes, there is an augmented clearance in patients with COVID also. So at that particular point of time, the drug dosing and is important, particularly when you have an augmented clearance, augmented drug clearance.
Good afternoon, everyone. Myself, Dr. Ayushi Tyagi. I would like to continue with this vibrant conference. We'll now begin with the international session for the day. The chairpersons for this session are Dr. Rajiv Upadhyay, Chairman Upadhyay Hospital, Agra, Dr. Rajesh Bhakchandani, Critical Care Consultant, Apex Hospital, Bhopal, Dr. Anup Kumar, Consultant and Chief, Critical Care Medicine, Baby Memorial Hospital, Calicut, and Dr. Prashant Kumar, Professor, Department of Anesthesiology and Critical Care, Pandit BDS, PGIMS, University of Health Sciences, Rohtak. I would now request Dr. Rajiv Upadhyay, sir, to kindly introduce our first speaker for the session.
Dr. Rajiv Upadhyay is not present at the moment. Dr. Prashant Kumar, can you please introduce the speaker, please?
Good afternoon, everyone, and thanks organizers to having me here. I'm very pleased to introduce Dr. Fernando Suprarigi Das, who is head of the Department of Critical Care at the Hospital Pompeia in Caxias, Brazil. And he was director Pontificia University, Colorado Grande, and of cardiac surgical unit from 89 to 97. And he has a very vast experience to share with us. So please, Dr. Fernando, please.
Good afternoon. Thank you to the organizers for the invitation to participate in the World Congress and COVID and Critical Care 2021. In the next few minutes, I will try to talk about the challenges faced and strategies during the pandemic in Brazil. I have no conflict to declare, and according to the organizers, my presentation will focus on preparation and timeline of COVID waves, the incidence, morbidity, mortality, and as general as the response, guidance, and tackle the pandemics, the therapeutics, infection, contaminant, vaccination strategy. Since the first case documented in Brazil in 26 February 2020, we have faced a lot of problems in our country. According to the Brazilian Superior Federal Court, on March 2020, it was constitutionally entitled to states and municipalities to implement public policies to control the COVID-19. This happens because the federal government have a lot of difficulties and initially deny the severity of the pandemics in our country. Since then, we have more than 21 millions of cases and more than 600,000 deaths, according to Johns Hopkins Coronavirus Resource Center, assessed on October 10th, 2021. As you can see, Brazil is one of the countries in the world with more cases and more deaths secondary to COVID-19. We have some studies about epidemiology in COVID-19 in our country. This study conducted by Bastos and colleagues showed the hospital admissions in the first and second wave. And you can see that in the second wave, in the 12th week of the epidemiology in this year, 2021, there is a great increase in the number of cases, transpassing 400,000 with a high level of demand in hospital admissions and staff consumptions that provoked a severe crisis in health in our country. This second wave have a very important role in Amazons. And in this state, the variant P1, that is 2.5 more times more transmissible, provoked an increase in the case of young adults, in the ICU admission, need for mechanical ventilation, increase in mortality also. The incidence, morbidity and mortality, according to the epidemiological weeks, in 3 times in Brazil, the confirmed cases show an increase from the first weeks in the beginning of the pandemics until the week 27, 30, by the end of the year of 2020. According to this, the number of hospital admissions increased in conjunction with number of new cases of COVID-19. And of course, as the pandemics advanced in our country, there was an increase in number of fatalities, mainly in the north and southeast and middle east country. As you can see, when we consider the age of patients, the need for invasive respiratory support, the number was increased, the admissions with patients below 60 years from 2020 to 2021. And there was a great increase in the number of patients in mechanical ventilation. In the second wave, occurs a severity increase in the number of fatality rates in these patients. One of the main causes of the increase in the contamination and the death rate was the poor management of precautions by general people, and in big cities, people don't respect the distancing between persons, and of course, the morbidity in patients with cardiovascular disease, diabetes, hypertension, obesity, contribution to a clinical picture of multiple organ failure, and in ultimate instance, corresponding an increase in number of deaths of patients with COVID-19. In this study by Ronzani and collaborators, we see an increase in the number of ICU admissions according to age, and the increase in invasive respiratory support according to age, mainly in patients above the 50 years, reaching around 75% the need for mechanical ventilation in these patients. This study was conducted in a private network of hospitals and showed maybe the same picture with number of younger patients increased, but here maybe secondary to the possibility of non-invasive respiratory supports, these patients before to use invasive mechanical ventilation, uses non-invasive ventilatory ventilation. And in this population, we can see a reduction in mortality in 6 days after the beginning of the syndrome. Facing this, the challenges that we need to fight during the pandemics, of course, I think that one of the most important was the lack of a central coordination and the responsibility of our federal government caused a lot of problems to states and municipalities because we don't have a clear evidence of communication. There was not respect the physical distance and lockdown in the big cities of the country. And because the federal government denied the severity of disease, the pandemics, the vaccination there was no beginning of vaccination until in a great number until the middle of 2021. And another problem that we faced, it was with the use of drugs without proven efficacy at the beginning of the symptoms of COVID-19. And this problem, of course, provoked a low procurement for hospital resource in patients with initial symptoms of COVID. These problems, of course, was of the domain of community scientific, and some publications describe the misinformation on social networks during pandemics in Brazil, showing that that was a big problem in our country. Despite this, some researchers in our country trying to focus in the domains to facilitate the access to intensive care, the organizational features, and mainly the process of care to reduce the impact of the pandemics, mainly in public hospitals. Of course, COVID-19 has specific challenges, and ICU beds and for the sicker patients and supply of equipment protection for health professionals was a big problem in our country also. The therapeutic interventions that use in the majority of hospitals in big cities was those adopted by the scientific community around the world. And our association, AMIB, develops a lot of guidelines to improve the care of these patients alongside the country. Our scientific community has conducted a lot of randomized controlled trials, some of them showing the low value of therapies like hydroxychloroquine and azithromycin in the treatment of mild to moderate COVID-19. The infection containment was a problem, because as I said before, our federal government don't see the pandemic as a sanitary problem and deny the importance of the social distancing in people, mainly in big cities. Some cities like Araraquara in São Paulo adopted a lockdown strategy and show a significant reduction in contamination in the number of cases along the pandemics. The vaccination strategy was a problem between federal and state government, and the authorization began in January 17, and the main groups that were vaccination are health professionals, elderly population, patients with comorbidities, and other people with vulnerability. In health professionals, there was a reduction in 62% in new cases of COVID after 2 months after to start the vaccination in these people. In concluding, the management of pandemic in Brazil suffered by the absence of central coordination. Unfortunately, our federal government have a lot of problems to recognize the severity and the importance of the pandemics. Misinformation, political conflicts, mainly between federal government and states, and the denial of severity of COVID-19 led to a high mortality in our population. The infection containment and the vaccination are crucial measures to flatten the curve of cases, and we have a problem yet with these aspects in Brazil. And the second wave, there was a lot of increase in cases in young patients and a decrease in mortality in this population. So finally, we can see that COVID has a great impact in health system and economics in Brazil, maybe like in all over the world in 2020 and 2021. Thank you for your attention.
Thank you, sir, for this comprehensive talk. I would now like to introduce Dr. Ross Freeburn. He's the intensive care consultant at Hawke's Bay Hospital in Hastings, New Zealand. He's an adjunct associate professor at the Chinese University of Hong Kong and medical director for New Zealand Air Ambulance Services. Professor Freeburn is the associate dean, University of Otago Medical School, and a member of the Basic Steering Group, and is involved in courses running in New Zealand, Australia, Africa, Asia, the Middle East, the Pacific, and Europe. I now hand over to you, sir.
Can we have the recording, please?
Thank you for inviting me to talk about COVID-19 in New Zealand. I've got a talk today that I'd like to, first of all, declare my interests. These are my associations or interests at the moment, none of which are particularly important. The opinions I give during this talk are my own and don't relate to any of those other organisations. So as of October 2021, we've only had 5,000 cases of COVID-19 in New Zealand, a very small number. We've been protected from this scourge. But more recently, in the last 14 days, we've had 745 cases, and today, 98 cases. Total deaths over the 2 years have been only 28. A vaccination program, there have been 6 million doses given The last 14 days, nearly 1 million doses have been given, and the number of fully vaccinated percent of the population is 56, although there are a large number of people who have had a single dose. So the timeline of COVID in New Zealand, the first case was identified on the 28th of February. By March the 16th, they had 8 cases, and the government mandated self-isolation for returnees, and mass gatherings of greater than 500 were banned. On March the 20th, in 2020, all the borders to New Zealand were closed. At that stage, there were only 39 cases, and by March the 25th, we went into national lockdown. This was a severe lockdown, and there were severe restrictions on people's movements. Businesses were closed, and apart from essential services, no activity was occurring within the country. One of the things that was of great concern to us in the ICU community was the relatively low number of ICU beds that were available to us. And we did the initial calculations based on what had happened overseas. It seemed we would be in deep trouble. Our ICU bed population at that stage was thought to be about 153, spread over 30 units. This is the second lowest rate in the OECD world, and it's 1/3 of Australia's capacity, our nearest neighbour, and 1/10 of that of Germany's. It was felt that New Zealand would have insufficient ICU beds to meet a surge demand driven from a widespread pandemic. Because of this and a number of other factors, the argument was made that elimination in New Zealand's case would be the best strategy. And Michael Baker and his colleagues argued strongly that this should be the case. And the government followed this advice and tried avidly to remove the virus from our community and preventing community spread. This was actually relatively easy for New Zealand because we were very isolated. You see, we're so isolated and forgotten about that on this map, in fact, we don't even appear. But our nearest neighbour, Australia, is 2,000 kilometres away, and we have a sea border surrounding us with ocean really to the west, north and south. It's very hard to get into New Zealand, and once the airline flights were reduced and controlled, it was impossible for the virus to get into New Zealand. We saw, as a result of lockdown, actually a reduction in the ICU work that needed to be done, rather than an increase that we had been expecting. Because COVID wasn't here, the number of unplanned admissions to all the ICUs fell over the period of the time of the lockdown. There was less trauma, less community spread, other diseases, and less other things that occurred. Over the same period of time, from February until December, the mortality in New Zealand actually fell rather than was raised. And this was in counter decision to just about all the other countries surrounding it. Our mortality actually fell significantly. By late 2020, we'd achieved elimination. There are no active cases, and despite some small times of flurries of small individual cases, there was no sustained community transmission. And in September, New Zealand moved to a level 1, regaining the freedoms that we'd lost during that time, and the crisis appeared to be averted. In 2021, on the 20th of February, the vaccination program started, and the trans-Tasman quarantine free travel bubble started. In August 2021, however, we entered a severe level 4 lockdown again because of a Delta case, a single Delta case transmitted in Auckland. The result of that is, as of October the 20th, 2021, Waikato, Northland and Auckland, about 30% of the population remain in level 3 lockdown, and the rest of New Zealand remains in level 2. So having thought we'd eliminated, we now have the problem with the virus. Our problem was that we still didn't have enough ICU beds, and the Minister of Health was asked about the number of ICU beds that were available in New Zealand. And he said there were 550 intensive care beds, and then a day or two later, he said there were 340 intensive care beds. And then on pressuring, he said that currently there are 284 intensive care beds. And he said there was an increase of more than 100 in the 15 months since COVID. Of course, no one really believed him after the third attempt to clarify these figures. And it was different from what the people at the coalface were telling him. This is the data from ANZICS, the Australian New Zealand Intensive Care Society, based on data that had been collected over some time. And as of October 2021, it appears that there are 172 beds in ICU and 14 fully staffed paediatric beds in the Starship Hospital in Auckland. Gives a total of 186 beds, or in other words, 3.65 per 100K. So the problem we had last year with the shortage of beds hadn't really been resolved. The question was raised of what is an ICU bed? Well, it's a physical bed with a well-imported environment. It requires equipment such as ventilators, syringe pumps, monitors, and dialysis equipment to appropriate standard, and it requires staffing. And while the government had gone to great lengths to acquire additional ventilators, monitors, and syringe pumps and other equipment, they hadn't really done much about increasing physical bed spaces in good ICUs. What they had done very little about was the staffing. And we felt there was a great shortage of nurses, doctors, and adult health people trained and experienced in intensive care to meet the surge capacity that had been promised by the government. I want to move now to stop talking about New Zealand, but talk about what we had done to try and address this issue. And I want to talk about the basic assessment and support in intensive care, or the BASIC course. This course was originated in 2004 as a result of the last SARS COVID epidemic. It was a group of clinicians, including myself, but led by Charles Gomersol and others at the Chinese University of Hong Kong, developed a course really in 2004, because in 2003, with the rapid expansion of intensive care units in Hong Kong, Singapore, and other places, as a result of SARS, there'd been a notable decrease in the quality of care and morbidity and mortality caused by the rapid expansion of these units and staff being unfamiliar with the techniques and standards that were required to run an intensive care unit. So the basic course was developed in 2004. Over the years, we continued to work on the course, and it was delivered in a number of places. We had, of course, the opportunity to develop it further, and we now had an app which had been developed in about 2016. The app was useful because it now delivered e-lectures, which could be delivered without a person having to be in a face-to-face environment. And the lectures were available on the app. The basic administrative course is run through a website, and importantly, it's possible to view whether clinicians who are enrolled in the course, the grey area here, as the names of the clinicians, you can view whether or not they have viewed the material. So prior coming to the course, it's possible to see if they're engaged with the material. We ran the course during the COVID lockdown. Here you can see us sitting in a intermediate school hall, a middle school hall. We managed to acquire this hall from the school because of the COVID lockdown, and there were no children at school. We used the hall to give us social distancing of space while we were doing the skill stations. There were numerous courses also run online. There was pre-reading, e-lectures, and online skill stations, and a post-course test. We were able to not only run these in New Zealand, but also run them in multiple other countries worldwide. This was impeded a little bit by the fact that they're a different time zone, New Zealand being way to the west of everything else, and often we're having to work through in the middle of the night to get into time zones that were comfortable for the participants. The logistics of doing it, language remains a problem, although English is widely spoken in the medical world, is not universal. And one of the things we did struggle with is the pre-reading and preparation that are essential for this course and were often missed. The website did assist us in seeing whether people had viewed the lectures prior to coming. It allowed us to remind people they needed to do some pre-reading. For the online ventilation simulator, we use a simulator. There's one by Hamilton, but several of the companies have simulators, allowing us to give a clear picture of what the ventilator looks like, and we can adjust the settings to follow the scenario. We also use video cameras and ventilators run by the instructor to demonstrate the skills required to run the ventilator. Over the 6 months from the start of the pandemic, we also ran 15 basic courses for nurses, and over 250 participants at 3 sites in Taranaki, Hawke's Bay and Otago, and other courses were run in a similar fashion using some of the material. Social distancing and the maintenance of isolation processes was challenging, but we used the pre-recorded lectures to reduce the contact time. Later on, we also developed a nurse COVID online version, and this allowed further nurses who are in more peripheral hospitals to also participate in the nurses course. We ran some in the smaller hospitals within New Zealand, and this photo you can see here is of the TTM National Hospital in Samoa, where the nurses were engaged in learning how to deal with ventilated patients. We've gone further to try and develop a mechanical ventilation part that is completely separated from requiring an instructor. That is a feedback loop, so that people can do the course without having to have an instructor present at the end of a computer. And it requires them answering a series of questions, which of course are still multi-choice. We've incorporated some COVID type material. Here's some questions about protective equipment and infection control as part of it. Our learnings for this is that we've found that the focus needs to be short lectures, which are pre-prepared, really focused skill stations that are short rather than prolonged. We need to allow time during the course for handing over and moving rooms, allow for breaks. And we found that the larger groups, which some people wanted to use, taints the interaction. It's hard enough interacting with COVID, with people using Zoom anyway, and large groups reduces the interaction. It's time consuming and less satisfying than face-to-face, particularly for the instructors. Over the last 16 years, we've now taught 84,000 people through the basic course, and there have been over 200 courses run in this last year alone. Just to sum up, to provide adequate intensive care capacity, you need a physical capacity, you need a bed space, but you need nursing and medical capacity, and you need adequate training, which is often short, particularly in times of crisis. Go back to New Zealand, we've had 94 community cases, 87 in Auckland today, and 7 in Waikato, 34 in a hospital. Fortunately, only 5 in intensive care. We're still in level 3 lockdown in Auckland. 54% are vaccinated, and the government is aiming for, well, they haven't named it, it's something like 95% vaccination to reduce the risk of a large burden on our healthcare system. Thank you very much for your time.
Thank you, sir, for this informative talk. I would now request Prashant, sir, to kindly introduce our next speaker for the talk.
So next in the international session, while we are sharing the international experiences, Professor Solomon Timsong Ratman, and he is head of the Department of Psychiatry, Sifako Magato Health Sciences University in South Africa. So I request Professor Solomon to share his experience from South Africa.
Can we have the recording, please? Hello, technical team.
Thank you very much for asking me to reflect on our experience in South Africa on the neuropsychiatric effects of COVID-19. My name is Professor Solomon Ratamani. I'm a practicing psychiatrist in South Africa, and I'm the chairperson of the Medical and Dental Board of the Health Professions Council of South Africa. I do not have anything to declare. I confirm that I prepared this presentation on my own. In the early stage of COVID-19 in South Africa, there was just rumblings of a serious illness from China that was going to affect the whole world. There was no real concern among African people and in South Africa and also in other African countries, because they thought this was a disease that was Asian in origin and it was not an African disease. However, late March to early April 2020, when first cases were detected, people started getting concerned. Number of infections were still low, but few people started dying, sudden deaths after admission to hospital. There was therefore general anxiety amongst most people, particularly educated ones, as deaths were registered. Government responded very quickly in collaboration with guidance from the World Health Organization and other countries such as Italy, China, and the United States. The president introduced level 5 lockdown, and a night curfew was imposed such that people could only travel up to 10 p.m., but no travel was allowed between 10 p.m. and 5 a.m. Restaurants were closed except for takeaway areas where possible. Flights in and out of South Africa were canceled. This therefore means suddenly there was a stop in terms of normal life in the country. Alcohol and cigarette sales were banned with moderate access and moderation later. World Health Organization regulations were implemented, and this included social distancing, washing of hands, and sanitizing, wearing of masks. This was initially not mandatory, but later it was legally enforced, particularly in public spaces and in shopping complexes. Movement from one province to the other was curtailed, except with permits that were given by government. And we had to specify what the purpose of travel was. There was recommendation that people, where possible, should work from home. Taxis and other transportation means were limited to a certain number of passengers per vehicle. There was obviously a very, very strong community response to this, because people suddenly felt that there was curtailment of freedom of movement and association. So they were very angry. There was panic when number of deaths increased. There was also fear of going to hospital, as these were seen as places where people go to die. At this stage, The whole world was struggling with a sudden surge of very sick people. There was a demand for more hospital beds and sudden increase in demand for oxygen supply in various forms. There was no clear treatment protocol in place for this illness that people and the practitioners in the front line did not understand. But these protocols were obviously developed later. A number of businesses were shut down and joblessness suddenly increased. Government introduced a relief grant, very little, and for most affected businesses and individuals. Government-sponsored personal protective equipment was put in place and introduced, but it was undermined by various scams that delivered cheaper and non-effective ones. And of course, this led to a number of deaths of frontline practitioners, such as doctors and nurses. Schools were closed and teachers and pupils were afraid to go back to school because the deaths were increasing in the country. So parents were asked to assist their children with learning at home. There were specific clinical interventions, including increased testing of people in all provinces, particularly around the epicenters that were identified from one province to the other. Laboratory tests were fine-tuned, and these were explained to citizens so that there should be no confusion. However, false positives and false negatives confounded the findings, but these were cleared with time. All deaths were checked for COVID-19, and when it was present, these deaths were notifiable so that we can get accurate statistics of people who died from COVID-19. Also, all comorbidities were documented, including diabetes, hypertension, other chronic illnesses that were there before COVID-19. There was a restriction in gatherings, for instance, limitations in terms of number of people who can go to church, who can be at celebrations such as weddings, and who can attend funerals. People are encouraged to present early for testing and go to hospitals early so that any form of intervention can at least reduce the severity of the illness and help people to recover. But despite concerted interventions, deaths continue to increase. So there were some clinical observations about these deaths, namely that most people died shortly after diagnosis and even soon after admission to hospital. There was also fear of being labeled COVID-19 positive, leading to late interventions. This means that there was also psychological stigma at being identified as being COVID-19. But this was obviously allayed by more communication from government channels. Mainly persons over the age of 60 were dying in the initial phase, but as the pandemic worsened, even younger people and much older people in the 70s, 80s were dying. Comorbidities such as diabetes, hypertension, obesity, HIV/AIDS, and other physical illnesses such as cancer were seen to accelerate the rate of death. And people were told to be careful if they have these illnesses and not to expose themselves to infection without any of the protections that were advised by WHO. Poverty and malnutrition was also implicated, and including underlying cardiovascular diseases. This was very important because most frontline workers had not checked for all these diseases. Then they were dying, and it was also noticed that when a frontline worker like a doctor died, a relative or a friend would also die. Government also included more interventions by establishing a national communication strategy, a central command that was led by the Minister of Health. Weekly messages and updates from the president were introduced. Efforts were made to dispel fake news and encourage citizens to behave responsibly. And this communication highlighted early signs and symptoms that may be related to being COVID-19 positive, such as dry cough, fatigue, weakness, loss of appetite, and in some cases, confusion and panic attacks, headaches, and other unexplainable physical symptoms occurring suddenly, including shortness of breath, sweating and dehydration, and later loss of taste and smell. The observed mental health effects included the following: a sudden increase in patients with acute anxiety disorders because of the underlying fear of death of themselves personally and of their friends or relatives. Severe anxiety and depression before and after admission to hospital, was noticed. All this above was made worse by uncertainty of when the pandemic will end. There was also a problem of loss of jobs, fear of dying, death of friends, death of colleagues and relatives. This added more stress to individual people who were affected. The suddenness of deaths and apparent absence of any effective medical treatments was also a concern. Researchers noted increase in relapses among mentally ill patients who were stable before, and some of these relapses were due to fear of going to clinics and hospitals for their usual treatment, so they were not getting their usual treatment. But others were due to the stress related to fear brought about by COVID-19 spread. It was also noticed that substance abuse, mainly use of alcohol, increased, and in young adults, use of substances such as cannabis and opioids to relieve stress and pain increased. A few patients presented with delirium as a first sign, or even acute psychosis in the early stage of illness. And later on, a number of people were diagnosed with post-traumatic stress disorder, which of course cleared up a little bit after interventions. There were also specific neurological effects, and this seemed to occur because of direct entry of the virus into the brain, causing direct injury to the brain. And this may include the following based on numerous studies and clinical observations in South Africa. Firstly, delirium, which confusion, disorientation in the early stage of the illness or at the height of the illness, encephalitis and meningitis, which was late in the illness and sometimes manageable. There was also very rare but observed epilepsy and seizures at any stage, but even if it was rare, it was noticed in some young and older people. In severe forms, some patients presented dementia and severe cognitive dysfunction with memory loss, failure to understand their surroundings, failure to enter into normal conversation. And those who developed strokes, though there were few, also had major depressive disorder. Some patients had transient ischemic episodes with fainting attacks and minor seizures. And there was also, and this was a persistent and commonly reported problem, severe and acute fatigue. This would be chronic in the later stage after hospitalization. Post-hospitalization, a number of patients presented weakness, general or specific, due to direct effect and damage to the nerve. And there was also lingering loss of taste and smell. In some patients, it took much longer to recover. And obviously, in alignment with mental illnesses, post-traumatic stress disorder was also diagnosed amongst those patients with mental illnesses. The overall response and observations were that hospitals and clinics were suddenly overburdened until practitioners understood the nature of the pandemic. More people became aware of the severity of the pandemic and asked for help earlier. The second and third waves of the pandemic were less severe, but deaths still occurred. Introduction of vaccines improved matters with fewer severely ill people. So the healthcare facilities were more prepared and rearranged to be ready for the pandemic. And when vaccination was introduced, the post-vaccination mental and neurological symptoms persisted in a small percentage, the so-called long COVID, which included extreme fatigue, weakness, anxiety, and depression. Although at almost 90,000 deaths in South Africa, for a population of 60 million, the situation in South Africa has greatly improved. And South Africa is now at the lowest form of lockdown, which is lockdown 1, very little in terms of restrictions, and more businesses are opening and starting to operate properly. But there is still a lingering fear of the fourth wave, and also a fear of more new variants of the illness coming up. However, the country is more prepared to deal with those variants. In conclusion, this is still work in progress, but there is hope that the pandemic will not be as destructive as in the early stages. Mental health services are functional now, and hospitals are adjusting to the new normal. The drive to vaccinate more people and develop herd immunity continues in full force, and this is led by the president of the country. I want to thank you for your attention.
Thank you, sir, for this enlightening talk. I would like to inform Dr. Mohammed Omar Farooq won't be able to join us today. We thank you all for contributing to the vibrancy of this conference, and we look forward to seeing you tomorrow and making this innovative event a great success. Thank you, everyone. Have a great day.